Good morning, one and all. Respected President Dr. Ajit Sir, respected Chief Guest, MLA and ex-Health Minister, Srimati Shailji Teacher, our guest of honor, DHS Dr. Ramesh Sir, our esteemed faculty, former Chief of IARC, Dr. Sankaranarayanan Sir, respected Vice President FOGSI, Dr. Tessie Lewis, Dr. Ashwat, past Vice President FOGSI, respected Vice President KFOG, Dr. PV Joseph, Vice President-elect KFOG, Dr. Omana Madam, our chairpersons of scientific section, Sharon Sir, Prasanamari Madam, Govinathan Sir, the office bearers of KFOG, senior members of the profession, and my dear friends. It is a pleasure to welcome you all on behalf of Oncology Committee of KFOG to this webinar on Path to Cervical Cancer Free Kerala. Cervical cancer is a preventable disease. It is also curable if detected early and treated adequately. But still, it is the fourth most common cancer among women worldwide and second most common cancer in India. And India contributes about 1/4 of the world's cervical cancer related mortality in Kerala. Cervical cancer is the fourth leading cancer with an incidence of 6.8 per 100,000 population in Kerala. 15 years back, elimination of a cancer was only a dream, but now we have cost-effective, evidence-based modalities to eliminate cervical cancer. And now, for the first time in the history of modern medicine, WHO has committed to eliminate a cancer. In August 2020, the World Health Assembly passed a resolution calling for elimination of cervical cancer and adopting a strategy to make it happen. In November 2020, the Director General launched the global strategy to accelerate the elimination of cervical cancer, including the following targets to be met by 2030. 1. 90% Hpv vaccination to all eligible girls. 2. 70% of women to be screened by a high-efficiency screening test by the age of 35 and 45, and 90% of women with a positive screening test for a cervical lesion managed appropriately. The launching event represents a historic milestone because it is for the first time 194 countries commit to eliminate a cancer unanimously. We can feel proud about the fact that India is one among them. The primary cause of precancerous and cancerous cervical lesion is infection with a high-risk oncogenic Hpv types. These Hpv 16 and 18 are responsible for 70% of cervical cancer worldwide and 85% in India. Hpv vaccination of adolescent girls is the most effective intervention for reducing the risk of cervical cancer. There is strong evidence that high Hpv vaccination coverage leads to protection of unvaccinated individuals through herd immunity. WHO's current guidelines recommend that girls between 9 and 14 years should only receive 2 doses of vaccine to get full protection. Data from Indian studies, it's from Sankaranarayanan suggests that a single dose vaccine also gives protection. Chandra sir is here. Let us learn from the legend. Most of the countries included Hpv vaccination in their national immunization schedule. Our neighboring countries of Sri Lanka, Bhutan, Myanmar, Thailand have already included. In India, Sikkim, Punjab, and Delhi have included Hpv vaccination in their immunization schedule. The Kerala state is almost always in the forefront in taking necessary steps to protect the health of our people. But unfortunately, we are waiting for the good news. The government is yet to take a decision. I would request Dr. Ramesh to take the necessary steps to make this happen at the earliest. Currently, there are 3 methods: cytology, VIA, and Hpv tests available for cervical screening. Cytology and VIA tests are relatively subjective with an average sensitivity around 50%. HPV testing is highly reproducible, objective, mechanically measured, and has a very high negative predictive value. WHO and FOGSI recommends HPV testing as a primary screening modality for CS cervix prevention, and the testing interval can be increased to 10 years. Unfortunately, we don't have an organized screening program. The Oncology Committee is conducting webinars in gynec societies and public awareness classes and also using social medias like YouTube videos to achieve this elimination by 2030. Now let me start the duty entrusted on me. Our KFOG president, Dr. Ajit sir, is very much encouraging and supportive of our Oncology Committee activities. I welcome you, sir. Today's chief guest is our own Shailaja teacher, MLA and ex-head minister of Kerala. We all know how efficiently Madam and her team handled the Nipah outbreak and Corona pandemic. We are lucky she informed her inconvenience to join the webinar, but Madam sent her video recordings of inauguration session to this send to us. And then our guest of honor is Dr. Ramesh, sir, DHS Kerala. He is an efficient administrator and a person and a well-proved leadership person of well-proved leadership quality. I welcome you, sir. Let me request sir to stay with us during the entire program. We are fortunate to have Dr. Sankaranarayanan, sir, the former chief of cancer screening group of IARC and the pioneer in cervical cancer prevention strategies in India. Sir is the advisor to Government of Kerala, Tamil Nadu, and so many other countries on cancer prevention and early detection. I welcome you, sir, on my own behalf and on behalf of Oncology Committee of KFOG. Let me welcome our chairpersons. Sharon sir is very keen on HPV vaccination and very much supportive to the activities of Oncology Committee. I welcome you, sir, to this meeting. Prasanna Madam, during her tenure, let me welcome our chairpersons. Sharon sir is very keen on HPV vaccination and very much supportive to the activities of Oncology Committee. I welcome you, sir, to this webinar. Prasanna Madam, during her tenure as KFOG president, Madam gave maximum importance to the screening programs. It was her dream to screen all eligible ladies in Kerala. Madam, we are working to fulfill your dream. Let me welcome Madam to this meeting. The man behind this meeting is Gopinathan sir. In his period as KFOG president, sir has given recommendation to the government to include HPV vaccination in our immunization schedule. I welcome you, sir. I welcome Dr. Tessie Lewis, FOGSI Vice President, Dr. P.V. Josa, Vice President KFOG, Dr. Ashit, past Vice President FOGSI, Dr. Romana Madhusudanan Madam, Vice President-elect KFOG, to this webinar. I welcome KFOG office bearers, my teachers, senior colleagues, and my dear friends who joined to this webinar. Now I invite Dr. Ajit sir, KFOG President, to give the presidential address. Anurag, Dr. Ajit is presently head of the Department of Obstetrics and Gynecology, Government Medical College, Kannur. He is also acted as past Vice President, Joint Secretary, past Chairperson, Research Committee, KFOG. Sir is also past President of Kannur ONG Society, fellow representative of AICC, RCOG. Over to you, sir.
Good morning, all. Respected Chief Guest, in her absence, our dear Shailaja teacher, Madam. Guest of honor, Dr. Ramesh sir, Director of Health Service. The keynote speaker, Dr. Sankaranarayanan sir. Our chairpersons, Jayagaran sir, Prasanna Madam, Gobi sir, Dr. Joe sir, Dr. Ashut, Dr. Tessie, Romana Madam, our dear Dr. Venu, and Dr. JEENA, and all seniors and dear friends. I take this opportunity to congratulate Dr. JEENA, our Oncology Committee Chairperson, for taking this initiative to make Kerala cervical cancer free. I know that from the day she has taken over the charge as chairperson, she is quite enthusiastic on this goal. cancer cervix is a preventable cancer. Even though, as Dr. JEENA mentioned, Kerala is leading in all health-related indices. We all know that when it comes to cancer cervical screening and prevention, we had to do lots of things. It is not the lack of awareness alone responsible for it. We need to develop a system to call all women timely for screening. You can take example of doctors, even gynecologists. How many of us are doing it? Is it because of the lack of awareness? But if there is a system to initiate to call all women every 5 years, as what is happening in developed countries, UK or US, it may work. Now we have vaccine. Again, we have to create awareness regarding it and make it available at affordable price, or we have to convince the government to make it under the national immunization scheme. Today, we were expecting Shailaja teacher for this function, but because of other engagement, she couldn't attend physically, but sent a video declaring our webinar to fight HPV inaugurated, expecting her full support in this endeavor. I am sure our Director of Health Service, Dr. Ramesh sir, will help us in our goal to eliminate cancer cervix from Kerala. Today we have the best faculty, Dr. Sankaranarayanan sir, to talk on the role of HPV, and we have the best of faculty and chairpersons, Chekaran sir, Prasanna madam, and Gopi sir. Expecting a wonderful webinar. Thank you all.
Thank you, Ajit sir, for your kind words and encouragement to KFOG Oncology Committee. Now I invite Dr. P.V. Joseph, Vice President KFOG, to introduce the chief guest. P.V. Joseph, yeah. He is working as professor in obstetrics and gynecology, Government Medical College, Kannur. He is a multifaceted personality who ventured in script writing and film direction. Over to you, sir. Joseph.
Yes, yes.
Please.
അഭിനന്ദനായ KFOG പ്രസിഡന്റ് ഡോക്ടർ അജിത്, ഏറ്റവും ബഹുമാന്യായ ചീഫ് ഗസ്റ്റ് ടീച്ചർ, DHS ഡോക്ടർ ആർ രമേശ്, മറ്റു പ്രമുഖ വ്യക്തിത്വങ്ങളെ, സെമിനാറിൽ പങ്കെടുക്കുന്ന സുഹൃത്തുക്കളെ, കഴിഞ്ഞ 5 വർഷം കേരളത്തിന്റെ ആരോഗ്യമന്ത്രിയായി പ്രവർത്തിച്ച ശ്രീമതി ശൈലജ ടീച്ചറെ എങ്ങനെ പരിചയപ്പെടുത്തണമെന്ന് എനിക്ക് നിശ്ചയമില്ല. കാരണം യഥാർത്ഥ മന്ത്രി ആരെന്നും എങ്ങനെയെന്നും കേരളത്തിനും ഒരുപക്ഷെ ലോകത്തിനും തന്നെ കാണിച്ചു കൊടുത്ത ഒരു മഹത്വമാണ് ശൈലജ ടീച്ചർ. 1956 നവംബർ 20 കെ കുണ്ടന്റെയും KK ശാന്തയുടെയും മകളായി കണ്ണൂർ ജില്ലയിലെ മാടത്തിൽ ജനിച്ചു. മട്ടന്നൂർ പഴശ്ശിരാജ കോളേജിൽ നിന്ന് ബിരുദവും വിശ്വേശ്വരയ്യ കോളേജിൽ നിന്ന് B.Ed ബിരുദവും കരസ്ഥമാക്കി. തുടർന്ന് ശിവപുരം ഹൈസ്കൂളിൽ അധ്യാപികയായി സേവനമനുഷ്ഠിച്ചു. 8 വർഷത്തെ സർവീസ് ബാക്കി നിൽക്കെ മുഴുവൻ സമയ രാഷ്ട്രീയ പ്രവർത്തനത്തിനായി 2004 സ്വയം വിരമിച്ചു. മട്ടന്നൂർ പഴശ്ശിരാജ കോളേജിലെ വിദ്യാർത്ഥിയായിരിക്കെ SFIയിലൂടെ രാഷ്ട്രീയത്തിലെത്തി. പിന്നീട് DYFIയുടെ സംസ്ഥാന കമ്മിറ്റി അംഗമായി. ജനാധിപത്യ മഹിളാ അസോസിയേഷൻ ജില്ലാ സെക്രട്ടറി, സംസ്ഥാന സെക്രട്ടറി, അഖിലേന്ത്യാ ജോയിന്റ് സെക്രട്ടറി എന്നീ സ്ഥാനങ്ങളിൽ പ്രവർത്തിച്ചു. മഹിളാ അസോസിയേഷന്റെ സ്ത്രീശബ്ദ മാസികയുടെ എഡിറ്ററായിരുന്നു. ഇപ്പോൾ CPIM കേന്ദ്ര കമ്മിറ്റി അംഗമാണ്. 2 പ്രാവശ്യം ഒരു പ്രാവശ്യം പേരാവൂരിൽ നിന്നും നിലവിൽ മട്ടന്നൂരിൽ നിന്നും നിയമസഭയിലേക്ക് തെരഞ്ഞെടുക്കപ്പെട്ടിട്ടുണ്ട്. മുൻ അധ്യാപകനും പൊതുപ്രവർത്തകനുമായ K. ഭാസ്കരൻ മാസ്റ്ററാണ് ഭർത്താവ്. 2 മക്കൾ, 2 പേരും ഉദ്യോഗസ്ഥരാണ്. 2 പുസ്തകങ്ങൾ എഴുതിയിട്ടുണ്ട്. ഇന്ത്യൻ വർത്തമാനവും സ്ത്രീ സമൂഹവും, ചൈന, രാഷ്ട്രം, രാഷ്ട്രീയം, കാഴ്ചകൾ എന്നിവയാണവ. അവരുടെ പ്രധാന വിനോദങ്ങൾ മ്യൂസിക്കും സിനിമ കാണലുമാണ്. അപ്പൊ സിനിമ കാണൽ എന്ന് പറഞ്ഞപ്പോൾ ഞാൻ എന്റെ സിനിമയെ പറ്റി പറയുകയും മാഡം അത് കാണാമെന്ന് സമ്മതിക്കുകയും ചെയ്തിട്ടുണ്ട്. അങ്ങനെ കേരളത്തിലെ ഏറ്റവും അധികം ജനങ്ങൾ ഏറ്റവും അധികം ഇഷ്ടപ്പെടുന്ന വ്യക്തി എന്ന നിലയിൽ ശ്രീമതി KK ശൈലജയെ ഞാൻ ഈ സദസ്സിനെ ഏറ്റവും ആദരവോടും അഭിമാനത്തോടും കൂടി പരിചയപ്പെടുത്തുകയാണ്. നമസ്കാരം.
ബഹുമാന്യരെ, KFOGയുടെ നേതൃത്വത്തിൽ സർവിക്കൽ ക്യാൻസറിനെതിരായിട്ടുള്ള വലിയ ക്യാമ്പയിനും പ്രവർത്തനങ്ങളും നടത്താൻ തീരുമാനിച്ചത് വളരെ ഉചിതമായി. ക്യാൻസറിനെതിരെ ശക്തമായ പ്രതിരോധം തീർക്കാൻ ഗവൺമെൻറ്റും തീരുമാനമെടുത്തിട്ടുണ്ട്. എന്നാൽ നമ്മളെല്ലാവരും ചേർന്നുള്ള വിവിധ മുഖങ്ങളിൽ നിന്നുള്ള പ്രവർത്തനത്തിൻ്റെ ഫലമായിട്ട് മാത്രമേ ക്യാൻസർ പൂർണ്ണമായിട്ടും മാറ്റിയെടുക്കാൻ നമുക്ക് സാധിക്കുകയുള്ളൂ. കേരളത്തെ ബാധിച്ചിരിക്കുന്ന ഏറ്റവും പ്രധാനപ്പെട്ട നോൺ കമ്മ്യൂണിക്കബിൾ ഡിസീസിൽ ഒന്നാണ് ക്യാൻസർ എന്ന് പറയാം. നമ്മൾ പല കാര്യങ്ങളിലും മുന്നിൽ നിൽക്കുമ്പോഴും ജീവിതശൈലി രോഗങ്ങളുടെയും അതുപോലെ പകർച്ചേതര വ്യാധികളുടെയും കാര്യത്തിൽ കേരളം വളരെ മുന്നിലാണെന്ന് പറയേണ്ടി വരുന്നത് ശരിയായിട്ടുള്ള ഒരു അവസ്ഥയല്ല. അത് കേരളത്തിൻ്റെ ആരോഗ്യരംഗത്തിന് വളരെ ഹാനികരമായിട്ടുള്ള ഒന്നാണ്. വലിയ ഉയർന്ന തോതിലുള്ള രക്തസമ്മർദ്ദം, അതുപോലെ തന്നെ ഉയർന്ന തോതിലുള്ള ഡയബറ്റീസ്, ഇതെല്ലാം കേരളത്തിൽ വളരെ വ്യാപകമാണ് എന്ന് നമുക്ക് കാണാൻ സാധിക്കും. ഇന്ത്യയുടെ ഡയബറ്റിക് ക്യാപിറ്റലാണ് കേരളം എന്ന് പോലും പറയാറുണ്ട്. ജീവിതശൈലി രോഗങ്ങൾക്കെതിരായിട്ടുള്ള വലിയ പ്രവർത്തനമാണ് കഴിഞ്ഞ ഗവൺമെൻറ്റിൻ്റെ കാലത്ത് നടത്തിയിരുന്നത്. എനിക്ക് ഓർമ്മയുണ്ട്, ഞാൻ ആ ആരോഗ്യ വകുപ്പിൻ്റെ ചുമതല ഏറ്റെടുത്തതിന് ശേഷം നടത്തിയിട്ടുള്ള ഒരുപാട് പ്രവർത്തനങ്ങളിൽ, ഗവൺമെൻറ് നടത്തിയിട്ടുള്ള പ്രവർത്തനങ്ങളിൽ ഒന്ന് ഈ ജീവിതശൈലി രോഗങ്ങളുടെ നിയന്ത്രണം ഉണ്ടാക്കുക എന്നുള്ളതാണ്. NCD കൺട്രോളിന് ആവശ്യമായിട്ടുള്ള കാര്യങ്ങൾ ഐക്യരാഷ്ട്രസഭയുടെ സസ്റ്റൈനബിൾ ഡെവലപ്മെൻറ്റ് ഗോളിൻ്റെ ഭാഗമായി നമ്മളും SDG പ്രഖ്യാപിക്കുകയും അതിൽ ഇൻഫെക്ഷ്യസ് ഡിസീസിനെതിരായിട്ടുള്ള പ്രവർത്തനത്തോടൊപ്പം തന്നെ നോൺ കമ്മ്യൂണിക്കബിൾ ഡിസീസിനെതിരായിട്ടുള്ള ഒരുപാട് ക്യാമ്പയിൻ പ്രവർത്തനങ്ങളും മറ്റു പ്രവർത്തനങ്ങളും നടത്തിയിട്ടുണ്ട്. 2018-19 ഈ ജീവിതശൈലി രോഗങ്ങൾ കുറച്ചു കൊണ്ടുവരുന്നതിൽ നമ്മൾ നടത്തിയിട്ടുള്ള ഇടപെടൽ ഐക്യരാഷ്ട്രസഭയുടെ ശ്രദ്ധയിൽപ്പെടുകയും ആ വർഷത്തെ അവാർഡിന് കേരളം അർഹമാവുകയും ചെയ്തു. എന്നാൽ ഇതെല്ലാം നമ്മൾ ചെയ്തുകൊണ്ടിരിക്കുമ്പോഴും ക്യാൻസറിൻ്റെ വ്യാപനം സമൂഹത്തിൽ ഉണ്ടാകുന്നു എന്നുള്ളത് തന്നെയാണ് നാം കാണുന്നത്. ക്യാൻസർ തടയുന്നതിന് വേണ്ടി ഒരു ക്യാൻസർ സ്ട്രാറ്റജിക് ആക്ഷൻ പ്ലാൻ നമ്മൾ ഉണ്ടാക്കിയിട്ടുണ്ട്. ക്യാൻസർ കൺട്രോൾ ബോർഡ് പ്രധാനപ്പെട്ട സ്ഥാപനങ്ങൾ രൂപീകരിക്കുകയും ക്യാൻസർ രജിസ്ട്രി, പോപ്പുലേഷൻ ബേസ്ഡ് ആയിട്ടുള്ള രജിസ്ട്രി തയ്യാറാക്കാനുള്ള നടപടികൾ ആരംഭിക്കുകയും ചെയ്തു കഴിഞ്ഞു. അത് നമ്മുടെ പ്രധാനപ്പെട്ട റീജിയണൽ ക്യാൻസർ സെൻ്ററുകളുടെ ആഭിമുഖ്യത്തിലാണ് ക്യാൻസർ രജിസ്ട്രി പ്രിപ്പയർ ചെയ്യുന്നത്. പോപ്പുലേഷൻ ബേസ്ഡ് ആയിട്ടുള്ള രജിസ്ട്രി മലബാർ ക്യാൻസർ സെൻ്ററും റീജിയണൽ ക്യാൻസർ സെൻ്റർ തിരുവനന്തപുരവും RCCയും അതുപോലെ കൊച്ചിയിൽ ഇപ്പോൾ തുടങ്ങുന്ന പുതിയ ക്യാൻസർ സെൻ്ററിൻ്റെയും നേതൃത്വത്തിലാണ് ഈ പ്രവർത്തനം നടക്കുന്നത്. അത് ഗവൺമെൻറ്റും പ്രൈവറ്റുമായിട്ടുള്ള എല്ലാ സെക്ടറുകളും ചേർന്ന്, എല്ലാ സംഘടനകളും ചേർന്ന് ഒരുമിച്ച് ഇടപെട്ടുകൊണ്ട് വേണം ഈ ക്യാൻസർ രജിസ്ട്രി രൂപപ്പെടുത്താൻ. അതിനാവശ്യമായിട്ടുള്ള പ്രവർത്തനങ്ങൾ രൂപീകരിച്ച് മുന്നോട്ട് പോകുന്നുണ്ട്, തദ്ദേശ സ്വയംഭരണ സ്ഥാപനങ്ങളെ കൂടി സഹായിച്ചുകൊണ്ട്. ഇതിൽ നമ്മൾ ക്യാൻസറിനെതിരായിട്ടൊരു യുദ്ധം തന്നെ പ്രഖ്യാപിക്കുകയാണ്. എന്ന് വെച്ചാൽ അതിൽ ആദ്യത്തെ നമ്മുടെ പ്രവർത്തനം ഏർലി ഡിറ്റക്ഷൻ തന്നെയാണ്. ചില ക്യാൻസറുകൾ ഒന്നാമത്തെ ഘട്ടത്തിൽ നേരത്തെ കണ്ടുപിടിച്ചാൽ അത് ക്യൂറബിൾ ആണ് എന്ന് തെളിയിക്കപ്പെട്ടിട്ടുണ്ട്. ചികിത്സിച്ച് ഭേദമാക്കാൻ സാധിക്കും. നിങ്ങളിപ്പോൾ വലിയൊരു ക്യാമ്പയിൻ നടക്കുന്നത് സെർവിക്കൽ ക്യാൻസർ അവസാനിപ്പിക്കാൻ വേണ്ടിയിട്ടാണ്. അതിനും ഏർലി ഡിറ്റക്ഷൻ വളരെ പ്രധാനപ്പെട്ട ഒരു ഘടകമാണ്. നേരത്തെ കണ്ടുപിടിക്കുക. പലപ്പോഴും പലരും പറയാൻ മടിക്കുന്നു. നമ്മുടെ പ്രൈമറി ഹെൽത്ത് സെൻ്ററുകളെ പോലും ഈ ഏർലി ഡിറ്റക്ഷന് പ്രാപ്തമാക്കണം. എല്ലാ ക്യാൻസറുകളും നേരത്തെ ഒരു പ്രൈമറി പരിശോധനയിലൂടെ മനസ്സിലാക്കാൻ കഴിഞ്ഞുവെന്ന് വരില്ല. എന്നാൽ കേരളത്തിൽ സ്ത്രീകൾ ധാരാളമായിട്ട് കണ്ടുവരുന്ന ഓറൽ ക്യാൻസറും ബ്രസ്റ്റ് ക്യാൻസറും സെർവിക്കൽ ക്യാൻസറും പ്രാഥമിക പരിശോധനയിലൂടെ സംശയിക്കാനെങ്കിലും സാധിക്കും. അങ്ങനെ സംശയം തോന്നിയാൽ കൂടുതൽ ഉയർന്ന കേന്ദ്രങ്ങളിലേക്ക് പരിശോധനയ്ക്ക് അയക്കാനും നേരത്തെ തന്നെ രോഗം കണ്ടെത്താനും കഴിയുമെന്നുള്ളതാണ് വസ്തുത. കവിളിലൊക്കെ ഉണ്ടാകുന്ന ക്യാൻസർ നമുക്ക് മറ്റു പല അസുഖങ്ങളുമായി രോഗികൾ ആശുപത്രിയിൽ PHCയിലൊക്കെ വരുന്ന, ഫാമിലി ഹെൽത്ത് സെൻ്ററിലൊക്കെ വരുന്ന സമയത്ത് സംശയിക്കാൻ സാധിക്കും കവിളിൽ ക്യാൻസറസ് ആയിട്ടുള്ള രീതിയിലാണോ അതിന് ഇൻഫെക്ഷനൊക്കെ ഉണ്ടായിട്ടുള്ളത് എന്നത് മനസ്സിലാക്കാൻ സാധിക്കും. ട്രെയിൻഡ് ആയിട്ടുള്ള ഡോക്ടർമാർക്ക് അത് മനസ്സിലാക്കാൻ സാധിക്കും. അതുപോലെ ബ്രസ്റ്റ് ക്യാൻസറും ചില സംശയകരമായ മുഴകളൊക്കെ അത് പരിശോധിക്കുന്നത് എങ്ങനെയാണെന്ന് പഠിപ്പിച്ചാൽ ആളുകൾക്കത് മനസ്സിലാക്കാൻ സാധിക്കും. ഇതൊക്കെ നേരത്തെ കണ്ടെത്തിയാൽ ചികിത്സിച്ച് ഭേദമാക്കാൻ സാധിക്കും. ആ കൂട്ടത്തിൽ വളരെ പ്രധാനപ്പെട്ട ഒന്നാണ് സെർവിക്കൽ ക്യാൻസർ. സ്ത്രീകൾക്ക് വരുന്ന ഈ രീതിയിലുള്ള ക്യാൻസർ നമുക്ക് കണ്ടെത്താൻ സാധിക്കണം. അതിനെ പൂർണ്ണമായിട്ട് നിയന്ത്രിക്കാൻ സാധിക്കണം. ഇന്ന് ലോകത്തിൻ്റെ നാനാഭാഗങ്ങളുമായിട്ട് 70,000-ഓളം കേസുകൾ പ്രതിവർഷം റിപ്പോർട്ട് ചെയ്യപ്പെടുന്നു എന്നാണ് മനസ്സിലാക്കാൻ സാധിക്കുന്നത്. കേരളത്തിലും ഈ സെർവിക്കൽ ക്യാൻസർ റിപ്പോർട്ട് ചെയ്യുന്നുണ്ട്. ക്യാൻസർസ് ആയിട്ടുള്ള എന്തെങ്കിലും തരത്തിലുള്ള ഒരു പ്രത്യേകത ഉണ്ടായാൽ അത് കൂടുതൽ പരിശോധനക്കും നിരീക്ഷണത്തിനും വിധേയമാക്കുകയും ചെയ്യണം. ഇതിൽ KFOG നിർദ്ദേശിക്കുന്ന കാര്യങ്ങൾ വളരെ സ്തുത്യർഹമാണ്. ഒന്ന്, ഏർലി ഡിറ്റക്ഷൻ സാധ്യമാക്കുക, പരിശോധന നടത്തുക. അതിൻ്റെ ഏജ് ഗ്രൂപ്പ് അനുസരിച്ച് തന്നെ ആളുകളെ ഒരു 35 വയസ്സൊക്കെ കഴിയുമ്പോൾ നിർബന്ധമായിട്ടും പരിശോധന നടത്തുക എന്ന ഒരു രീതി അവലംബിച്ചാൽ നമുക്ക് ക്യാൻസർ കണ്ടുപിടിക്കാൻ സാധിക്കും. ഇത് പ്രത്യേകിച്ച് HPV വൈറസ് ആണ്. എല്ലാ വൈറസ് ഇൻഫെക്ഷനും ക്യാൻസറായിട്ട് മാറണമെന്നില്ല. എന്നാൽ ക്യാൻസറായി മാറാൻ സാധ്യതയുള്ള തരത്തിലുള്ള ഇൻഫെക്ഷൻ കണ്ടാൽ അത് കൂടുതൽ വരുന്ന പരിശോധനയ്ക്ക് വിധേയമാക്കിയാൽ ക്യാൻസർ ആണോ എന്ന് മനസ്സിലാക്കാനും ട്രീറ്റ്മെൻറ്റ് എടുക്കാനും കഴിയും. സർവിക്കൽ ക്യാൻസർ നേരത്തെ കണ്ടുപിടിച്ചാൽ പൂർണ്ണമായും ചികിത്സിച്ച് ഭേദമാക്കാൻ കഴിയുമെന്ന് ശാസ്ത്രലോകം തെളിയിച്ചിട്ടുണ്ട്. അതുകൊണ്ട് ആ പരിശോധന നേരത്തെ നടത്തണം. അതിൻ്റെ കൂടെ ഏറ്റവും പ്രധാനമായിട്ടുള്ളത് ഈ HPV ഇൻഫെക്ഷന് അതിനെ പ്രതിരോധിക്കാനുള്ള വാക്സിൻ ഇപ്പോൾ ലഭ്യമാണ് എന്നുള്ളതാണ്. അപ്പോൾ അത് ഉപയോഗപ്പെടുത്തിയാൽ ക്യാൻസർ വരുന്നത് പൂർണ്ണമായിട്ടും തടയാൻ കഴിയും എന്നുള്ളതാണ് KFOG മുന്നോട്ട് വെക്കുന്ന ഏറ്റവും പ്രധാനപ്പെട്ട കാര്യം. ഈ ആശയം ജനങ്ങളിൽ എത്തിക്കുകയും വാക്സിനേഷൻ ആവശ്യമായിട്ടുള്ള സൗകര്യങ്ങൾ ഉണ്ടാക്കിയെടുക്കുകയും ചെയ്യാൻ നമുക്ക് സാധിക്കണം. അതിന് ഗവൺമെൻറ്റും പ്രൈവറ്റ് മേഖലയും എല്ലാം ഒരുമിച്ച് ചേർന്നുകൊണ്ട് അത്തരത്തിലുള്ള പ്രതിരോധ പ്രവർത്തനങ്ങൾ ചെയ്യാൻ സാധിക്കണം. ജനങ്ങളെ ഇക്കാര്യത്തിൽ ബോധവൽക്കരിക്കലാണ് ഏറ്റവും പ്രധാനമായിട്ടുള്ള കാര്യം. അതെല്ലാവരും ഒരുമിച്ച് ചേർന്ന് വിചാരിച്ചാൽ സാധിക്കും. ഏതായാലും KFOGയുടെ ഭാഗമായിട്ട് ഏറ്റവും പ്രധാനപ്പെട്ട ഒരു പ്രശ്നം ആരോഗ്യ മേഖലയിലെ അതിന് പരിഹാരം കണ്ടെത്താനുള്ള കൂട്ടായ പരിശ്രമം നടത്തുന്നു എന്ന് കാണുന്നതിൽ ഈ വകുപ്പ് മുൻപ് കൈകാര്യം ചെയ്തിട്ടുള്ള ഒരാൾ എന്നുള്ള നിലയിലും എനിക്ക് വലിയ ചാരിതാർത്ഥ്യമുണ്ട്, നന്ദിയുണ്ട്. നമ്മുടെ ഗവൺമെൻറ് ഈ തുടർച്ചയായിട്ടുള്ള ഇപ്പോഴത്തെ ഗവൺമെൻറ്റും ആരോഗ്യ മേഖലയ്ക്ക് വലിയ പ്രാധാന്യമാണ് കൊടുത്തിട്ടുള്ളത്. പുതിയ ആരോഗ്യവകുപ്പ് മന്ത്രിയും ഇത്തരം കാര്യങ്ങളിൽ വലിയ താല്പര്യമാണ് കാണിക്കുന്നത്. അതുകൊണ്ട് തന്നെ ഗവൺമെൻറ്റിൻ്റെയും അതുപോലെ തന്നെ മറ്റ് സംഘടനകളുടെയും എല്ലാം ഒരുമിച്ച് ചേർന്ന പ്രവർത്തനത്തിലോടുകൂടി ഈ ഓരോന്നും, അപ്പോൾ സർവിക്കൽ ക്യാൻസർ മാത്രമല്ല ഓറൽ ബ്രസ്റ്റ് ക്യാൻസർ എല്ലാം തന്നെ അത് ഏർലി ഡിറ്റക്ഷന് നമുക്ക് കഴിയണം. അതുപോലെ പ്രതിരോധ വാക്സിൻ ഉള്ളതിനെല്ലാം പ്രതിരോധ നടപടി സ്വീകരിക്കാൻ നമുക്ക് സാധിക്കണം. അങ്ങനെ ക്യാൻസറിനെ തടയാൻ, ക്യാൻസറിനുമായിട്ടുള്ളൊരു യുദ്ധത്തിൽ വിജയിക്കാൻ നമുക്ക് സാധിക്കണം എന്ന് മാത്രം ആഗ്രഹിച്ചുകൊണ്ട് KFOG നടത്തുന്ന ഈ പ്രവർത്തനത്തിന് അഭിവാദ്യങ്ങൾ അർപ്പിക്കുന്നു. ഞാൻ ഈ പരിപാടിയുടെ ഔപചാരികമായിട്ടുള്ള ഉദ്ഘാടനം നിർവഹിച്ചതായി സ്നേഹപൂർവ്വം അറിയിക്കുന്നു.
താങ്ക് യു മാഡം. ഗവൺമെന്റ് ക്യാൻസർ പ്രിവെൻഷന് ഇത്രമാത്രം പ്രാധാന്യം കൊടുക്കുന്ന ഈ ഘട്ടത്തിൽ സർവിക്കൽ ക്യാൻസർ നമുക്കും അതിൻ്റെതായ രീതിയിൽ സർവിക്കൽ ക്യാൻസർ പ്രിവെൻഷനുള്ള സ്ട്രാറ്റജീസും നടത്തി ഈ എലിമിനേഷൻ പോസിബിൾ ആക്കുമെന്ന് നമുക്ക് പ്രതീക്ഷിക്കാം. Now I invite Dr. Ashok Kumar to introduce our guest of honor.
Good morning, everybody.
Ashok is working as professor, Department of Gynecology, Jubilee Mission Medical College. He is the past president of FOGSI and past vice president FOGSI and KFOG. To you.
Okay. Okay. Good morning, everybody. Respected President KFOG Ajit sir, Vice President PV Joe sir, our Chief Guest Shailaja teacher, Madam, the Guest of Honor Ramesh sir, Sankaranarayanan sir, my friend Pesi, Omana Madam, Shegaran sir, Prasanna Madam, Gobinathan sir, and my friend Venu, Secretary KFOG. It was always happy to be a part of such an important program to make cancer, Kerala cancer free of cervical cancer. And I know JEENA Madam, before taking over the position of the chairperson of Oncology Committee in Kerala, she was a part of FOGSI Oncology Committee, also doing a lot of works in South India. So her passion to cancer prevention, we all know. So, and once, as Ajit sir told, once she has taken over the committee chairpersonship itself, she is so enthusiastically working. Every day she has created group. Everybody in our association is now aware that we have to work for cancer prevention, and hope in her 3 years she will be able to make Kerala cancer free. Maybe it is little over ambitious, but hope that things happen. Now I come to my pleasant duty, what she has given me. We all know that without the help of a government system or an efficient people, like Ramesh, Dr. Ramesh, Ramesh, we may not be able to have this dream possible. So I am introducing Ramesh sir. He's a project director of Kerala State AIDS Control Society, former director of Health Service, and more important, you will all know him as the past state president of IMA. So many prestigious posts he has been. With his help and with the involvement of the government, we will be able to eliminate cancer from Kerala. Thank you once again. Thank you, sir.
Thank you, Dr. Ashit, for your good words. Thank you, Dr. JEENA, for giving me this opportunity. The most respected chair of this meeting, Dr. Ajit, the president of KFOG. My most respected teachers, there are many teachers, my teachers, respected teachers participating in this webinar. Dr. Sankaranarayanan and my dear colleagues, senior members of the profession, and my dear friends. First of all, let me congratulate KFOG for undertaking such an important project of Path to Cervical Cancer Free Kerala. Actually, it's really a good idea and a wonderful project to think of to implement in Kerala. So let me congratulate all the KFOG, the president, all the members, and also their oncology committee chairperson, Dr. JEENA BABURAJ, for the initiative taken. We all know that cancers is always a very important public health issue. It's a very challenging public health issue. And it's just not a health issue. Cancers also disturbs the socioeconomic issues of a family too. So it is just not mere public health issue, but it's also a socioeconomic issue. And it's really a burning community problem, any cancer. As far as I think the cancer seen in women in Kerala, cervical cancer comes 1 in 3, one among the 3 most cancers seen in women in Kerala. I think it's the breast cancer, thyroid cancer, and the cervical cancer, as for the latest data we have. So cervical cancer is also very important that if we can intervene at the right time, in the right direction, in the right way, it is 100% preventable. So definitely, KFOG has taken up a mission which is 100% possible also. As far as the government of Kerala is concerned and the state health department is concerned, we have a very good cancer program for prevention as well as the management and rehabilitation of cancer patients, and we call it as Abhayam. It has been there for years. We have a state nodal officer, Dr. Bibin, who is looking after this program in a wonderful manner. We have developed a system where we involve many of the stakeholders. There is interdepartmental coordination. We work closely with the LSGD department, the Social and Justice Department, and Women and Child Department in the cancer program. Even though we have 2 major cancer centers in Kerala, that's the regional cancer center here in Trivandrum, and the another one is the Malabar Cancer Center at Thalassery. Both the institutions are of international level, and very good facilities are there, and so our pivotal institutions are these 2 centers. But under the state government or the health department, we have 24 cancer care centers, secondary cancer centers, working in district hospitals and some of the major institutions under the Department of Health and Family Welfare, where we have trained the medical officers and the staff nurses, and they take care of the patients at a secondary level. Means when they are diagnosed and they put on treatment at the Malabar Cancer Center or the Regional Cancer Center, we have a follow-up mechanism there in these district centers, including giving chemotherapy as well as palliative care and any other services which we require for the cancer patients. And also, our department closely works with the local self-governments. the district panchayat or the block panchayat or the grama panchayats, they have their projects under the health for the cancer patients. We have done a lot of projects through the LSGDs. Now the concept of family health centers have also come in the Department of Health and Family Welfare. So this concept has changed the primary healthcare in our state. Now we are giving training to these medical officers in the line of a family doctor, and also we have other staff also getting trained. And even the services provided at these family health centers are more elaborative than the earlier primary health centers. So these family health centers also play a big role in the prevention of NCDs as well as in awareness creation and prevention of cancers also. And the government has also had a program called the Sugrudam, wherein the BPL patients, the cancer patients, were given free treatment up to ₹3 lakhs. Of course, certain fund issues sometimes hinder the smooth functioning of this program, but still it's on, and subject to the availability of fund, definitely we are moving in this this program. And another good intervention the health department under the Directorate of Health Services now is doing is we have developed a plan for HPV screening in women using the 19 TrueNat machines available with a TB control program. So we have this TrueNat machine, just that cartridge has to be changed, and these 19 TrueNat machines can be used for HPV screening. So these are the interventions which the health department is doing. As far as I think KFOG, you have a very good, you're all experts in this field, and you have a very good brain, a combination which can definitely bring in a very good action plan for this parts of cervical cancer free Kerala. I feel that we need to create more awareness, as Dr. Ajit is in his presidential address was saying. Yeah, of course, it is not the behavioral, it is not just the awareness. We say the IEC, that is the information, education, and communication. But in most of the diseases now, what we see that how we translate this IEC into BCC, that is the behavioral change communication. So Dr. Ajit was mentioning, I was not surprised how many of the gynecologists itself undergo this pap smear when they are supposed to do. It's not that we don't know. That's what we said. So the concept of IEC now changes to BCC. Even in COVID, what we are seeing is now, because for the last 1.5 years, we've been telling SMS, we've been asking them not to go out unnecessarily, but still people will not just follow the COVID appropriate behavior or the protocol. That is not because they don't know. It is because of the attitude and the behavior. So such things also have to be addressed. So the behavioral change, attitude, the change, the communication, the attitude change, communication. And another thing which I feel is a reproductive and sexual health, that has to be addressed at the at the high school level itself is what I feel. That is a bit not done by the school teachers. So we need to orient the school teachers, especially the science teachers and even the class teachers. They are a very influential group on these students, what I understand. Right from the high school itself, the reproductive and sexual health education has to be strengthened. As far as the cervical cancer, the path to cervical cancer free Kerala is concerned, I think one thing is that it is 100% treatable if diagnosed very early or even in a pre-cancer stage. It is only one cancer. It is one of the very few cancers which we can diagnose even in the pre-cancer stage. So we need to have that action, and for that health information and warnings have to be done. And one area where I understand we are falling behind is the STI care, the sexually transmitted infection care. See, now I'm holding the charge of Project Director of Kerala State AIDS Control Society. We have 23 STI clinics functioning the whole Kerala in the government institutions. And these clinics are functioning in the medical colleges as well as the district or the general hospitals. But when I see the data which is available with the services provided in these STI centers is very dismal. The client load in these centers are very low. Why is it? Because we don't get referrals from the doctors or the other departments, even in medical colleges and the district hospital or general hospital. So though I think that STI care has to be improved drastically in our state, and we can do a lot of good things in this. So I feel KFOG can help us. Kerala State AIDS Control Society is definitely trying to improve this STI care, because our aim is to for HIV, zero HIV by 2030. That is our SDG target. So I think HIV as well as even this cervical cancer will fit into this our STI program. We will definitely take it up with the help of KFOG. And one thing which has been highlighted everywhere is the HPV vaccination. Definitely, we also feel that we need to include this in our routine immunization schedule. So when we conduct this STAGI, that is a state technical group, a technical advisory group for immunization, which gives strong recommendations. I think in the next STAGI meeting, we will try to enforce, or we'll try to see this STAGI gives a strong recommendation of including HPV vaccination in our routine immunization, so that the girls by 15 years, they get vaccinated. I think this HPV vaccination, which is now internationally accepted and is implemented in many of the countries, definitely need to be implemented. And of course, we need, so the strategies will be early reproductive sexual awareness in children. And second thing is awareness of sexual health throughout the general population, importance of vaccination, importance of increasing the screening of women to early diagnose cervical cancer. And also, once we diagnose, we need to ensure that better treatment facilities are there for managing these cases. I think these are the interventions which we need. And definitely advocacy, IEC, BCC, community mobilization is the key for all these activities. And when I say community mobilization, I think it should also at the first stage before community, I think it should be these all things should be communicated to our own healthcare professionals, including the doctors, the general practitioners, and all the doctors, irrespective of their specialty. I think we need to mobilize our doctors also, and also for the community. And for the community, we need to increase access to these interventions. So that the concept of family health center has come, so that has increased the accessibility. And I think KFOG also can help us in monitoring and surveillance aspects, and also good research activities in this field. I think these are the thoughts which I thought I would like to share you on this on all-important day where you are discussing a very important topic, the path to cervical cancer-free Kerala. So once again, I congratulate KFOG for taking up this project. And on behalf of the Department of Health and Family Welfare, we fully support your project. And it's a mutual support we are getting from KFOG for so many years. Paili sir has been our mentor and guide for so many activities in IMR and MMR reduction, and what and all we have achieved in MMR reduction. And also subsequently IMR reduction is definitely the main contribution has come from KFOG, and of course IAP also. So once again, let me congratulate you all for very effective interventions in the health of our state, and let me wish you all the best for this project, and we hope to have a cervical cancer free Kerala very soon. Thank you.
Thank you, Ramesh sir, for the full support he is giving us. And this government has taken up HPV screening as the screening strategy to CS prevention. It's a very good news to us. Now it is the time for felicitation. Let me invite Dr. Fessy Lewis. Dr. Fessy is currently working as Associate Professor, Department of Reproductive Medicine and Surgery under the Institute of Medical Science, Kochi. He is the current Vice President, FOGSI. There's a lot of credentials to his name. He's the office bearer of many national and international organizations, and or he's a very good orator and has a lot of awards in his credit. So, Dr. Tracy, over to you.
Thank you, Dr. JEENA. I think respected KFOG President Ajit Sir, Secretary Venu, Vice President Joe Sir, Vice President-elect Omna Madam, and all the dignitaries, chairpersons, and our invited speaker, Sankaranarayanan Sir. So I take this a proud privilege to be here, and I am extremely happy that Dr. JEENA BABURAJ has taken this initiative. I still remember how dedicated she was in the cervical cancer prevention idea in her mind, because 2 years back when I was a KFOG editor, I still remember she has been giving, I gave 2 or 3 articles in that span of 3 years regarding the cervical screening, vaccination, all those things even at that time. I think now our oncology committee is in the right hands, and she has been so proactively taken the initiative in this cancer-free Kerala, cervical cancer-free Kerala. And I am also happy that we have got, even though she could not come, our previous health minister was a chief guest, and so gave us so motivational speak regarding this subject. We know how well-read she is. We remember how she addressed to us our general body during the All Kerala conference in Thrissur, and also the guest of honor, Dr. Ramesh. Even though he is now the DHS in charge of AIDS control, I still remember being once traveled with him at 2 a.m. in the early morning when we were sitting in the Bombay airport. At that time, he was the IMA State Secretary, and still he was working on the computer. So how he has actively committed to our cause and agreed to our KFOG initiative and the initiative by Dr. JEENA. And I hope we will come in a fruitful decision. As Ajit Sir told, not only the cervical cancer vaccine, even though it is a little costly thing, and that's why it is not widely accepted, but the cervical screening part. We have to, as Sir told, how many of the gynecologists or the being male gynecologists, how many of you are been doing their wives' cervical cancer screening routinely? That is a thing we have to think ourselves. And like in Columbia State in Canada, where we all study during right from our MBBS times, the example of cancer screening, or most of the European countries where it is mandatory. You have to do that every 5 years for a preventive cancer like cancer cervix, then only your health insurance will be renewed. So like that, something has to be made mandatory. Even the population is a big concern for us, but at least the cervical screening has to be emphasized and made as awareness has to be inculcated into all the gynecologists and all the doctors and the whole the population. That's what the primary aim has to be. I think this today's keynote address by Sankaranarayanan Sir will definitely give us more insight and more proactiveness for this endeavor. And as a FOXI Vice President, as you all know, Dr. JEENA was also the member of the FOXI Oncology Committee. We have a separate committee for that. And I assure that from the FOXI side, All India side, in the next, I just took a charge only 2 weeks back, next 1.5 years, where clearly sort out different programs out of the one of the priorities is the cancer screening. And on this World Population Day, I bring greetings from the FOXI and wishing all the success for Dr. JEENA BABURAJ in her endeavor and for today's webinar. Thank you for calling me.
Now I invite Dr. Omana Madam for felicitation. Madam is the head of the Department of Obstetrics and Gynecology, Vinayaka Hospital, Sitandatheri, and Vice President-elect, KFOG. To you, Madam.
Respected Chief Guest of the Day, Shailaja Teacher, our guest of honor, DHS Dr. Ramesh, our renowned keynote speaker, Sankaranarayanan Sir, Dr. Ajit. So, respected Chief Guest of, yes, Shailaja Teacher, our guest of honor, Ramesh Sir, and our renowned keynote speaker, Sankaranarayanan Sir, Ajit Sir, JEENA Ma'am, Shekaran Sir, all my teachers, senior friends, seniors and colleagues. It's my proud privilege to felicitate for today's function. It is a great initiative on the part of KFOG, headed by Dr. JEENA, to start this project to fight HPV and eliminate cervical cancer. And our Wayanad Society had the privilege of releasing this logo on that particular day. Now we are trying to create awareness among public through webinars, among NGOs, health workers, and also Kudumbashree workers and all. But as Ajit said, we should have a protocol. And when we always take webinars, we say, as Dr. JEENA BABURAJ said, all the girls should insist their mothers to get screened, and all the mothers should insist their children to be vaccinated. I think when somebody else's forces for this, we'll be more obliging. Now, hope without teamwork, we will be able to achieve this goal. And wishing all the best for today's webinar. And I'm sure we'll all have many take-home messages after this webinar. Thank you.
Thank you, Amina Madam, for this nice words. Now we are moving to the well-awaited scientific program. We have three well-known chairpersons. I am introducing our chairpersons because it is customary. Professor Sharon sir. Professor Sharon sir, as you all know, is the former professor and head of the Department of Obstetrics and Gynecology, Government Medical College, Calicut. Is the Vice President FOGSI 2010, President KFOG 2003 and 2004, Organizing Chairperson, 9th World Congress of Gestational Trophoblastic Disease 2009, Secretary and Treasurer, International Society of Gestational Trophoblastic Disease 2013 and 17, Visiting Professor, Peking University, BG, Member of FIGO Writing Group on Gestational Trophoblastic Disease 2015, 18 and 2021. Sir has delivered many orations, including M.K. Krishnamenon, D.N. Purandare, and A. Patnarao orations, also the MOX, N.A. Pandit, and Shailaja N. Pandit Award for Women Empowerment. There's 41 publications in international and national journals, and he has given read chapters for PG textbooks. And next slide. And sir is our mentor. And Prasnavamari Madam, she's the consultant gynecologist, Lifeline Hospital Addo, former professor, Medical College Trivandrum, author of the book Postgraduate Gynecology. She's awarded WHO Fellowship in 1991, and she is former president of KFOG. And next is our Govinathan sir. He's a retired Deputy Director of Health Service, Superintendent of Government General Hospital, Talseri, past President, Kannur ONG Society, past President, KFOG, past President, KFOG, and President, Doctors Corporate Society, Talseri, served IMA in various capacities, President, Secretary, Social Security Scheme, Chairman, Mutual Benefit Scheme, Chairman, Finance Committee, Chief Election Commissioner, and Workplace Office Bearer of KGMOA for 10 years, and at present Secretary, IMA National Pension Scheme, and National President of SPSS. Now I request Sharon sir to introduce Sankaranarayanan sir and request the chairpersons to conduct this scientific session.
Respected Chief Guest, Madam Shailaja Teacher, Guest of Honor, Dr. Ramesh, DHS of Kerala, our Dr. Sankaranarayanan, President of KFOG, Dr. Ajit, Vice President of FOGSI, Dr. Pessi Louis, past Vice President of FOGSI, Dr. Ashwath, Vice President of KFOG, Dr. P.V. Jose, Vice President-elect, Dr. Vamana Madhusudanan, Secretary General, KFOG, Dr. Venu, and all my colleagues from KFOG and their delegates. As we all know, cancer service is a preventable cancer. It's a treatable cancer. And if you detect it properly at the correct time, because we have got almost 10 years ahead, we may see the warning signs of a cancer service. So if you diagnose and treat it, you are curing that condition. The WHO has launched the resolution in 2020 that by 2030, we should be able to eliminate cancer cervix from the world. By elimination, WHO means less than 4 per 100,000 population, the incidence has to be reduced. By the three-pronged attack, one is vaccination of at least 90% of the eligible girls up to 15 years, at least by 2 doses. The screening of the women of 35 and 45 up to at least coverage of 70%, and treatment of 90% of the identified cases, early cancer screening, including the palliative care. And by this, we hope by 2050, the incidence of cancer cervix may be reduced by 50%. And by the next century, we will be hoping to eradicate the cancer cervix, and the next generation will remember us for what we do today. So the most important thing is, vaccination. Many countries or the affluent countries have achieved many things in the vaccination field. But I am happy to see countries like Bhutan, Nepal, Maldives are also way ahead than in India. I think this is because of the international agency's support. And we must get the help from Dr. Sankaranarayanan, how to get this found from the international agencies, so that, because vaccination is not a simple thing, it is a costly affair, and we have to have money for mobilization of this vast program of vaccinating all the girls, if not the boys also. And I think Dr. Sankaranarayanan can help us. The resources available in the world agencies, I think the Bhutan, Nepal and Maldives have achieved this goal of even covering 70% or even 90% of the vaccination program in their country because of the world help from the World Organization, which we are not able to tap it so far. We are, as we said that earlier, we are way ahead in health issues, health indices compared to other part of India. But we are still not started the vaccination program. Even the state like Punjab and Delhi, they have started. So it is high time we think of it, and the government, without the government support, the KFOG or any other NGOs cannot do anything because a lot of money is involved. Also, the screening program has to be with a government push only we can do, because as an organization, I remember even 30, 40 years back, we started doing some screening program, but it didn't produce an impact on the society because it is a minuscule of the population that we could screen with a lot of difficulties. So unless the government is coming forward with a compulsory mode of screening program, which the KFOG will be helping because of the personnel we have got, with the technical help we can provide, but not the money of massive money involved, especially with the Hpv vaccination. And I am very happy to see Dr. Sankaranarayanan amongst us to give the keynote address. We will learn from him a lot. He is a researcher in the field of preventive oncology. He has worked extensively in the screening programs and prevention. He was with as the head of the preventive oncology at the International Agency for Research in Cancer, with its headquarters at Lyon, France, for a long time. And he is now also a visiting consultant for the WHO-sponsored International Agency for Research in Cancer. He is director of the Preventive Oncology Carcinos. It is a health facility with a motto that nobody, because of the lack of money or other resources, should suffer from any disease, especially from cancer. I think the Carcinos comes from the wild crab or something like that, is represent the cancer, I suppose. Extensively research papers are there, more than 260 papers to his credit. He has traveled all over the world, at least in more than 100 countries, and giving support and help in cancer prevention. He's advised to Tamil Nadu and government of Kerala also, and many other Southeast Asian countries. Of course, he is an MD in radiation oncology. So, sir is going to tell us the ways and means of our dream of reaching somewhere in the disease prevention by vaccination, as well as detection by early cancer detection and treating and eliminating the cancer burden. So I think we can invite him, or as per your this thing. So we have got a great opportunity. We have to utilize sir for all the advices that we can get, and he is ready to help us. I am very sure that we will have to utilize him very much. Thank you, JEENA, for this chance.
Thank you very much for your kind words, Professor Sayaran. Respected Madam former Minister of Health, Srimati Shailaja Teacher, respected Director of Health Services, Dr. Ramesh, Dr. JEENA BABURAJ, who is the chairperson of the Oncology Committee of KFOG, Professor Sayaran, my dear classmate Prasanna Kumari, Dr. Gobinathan, Dr. Ajit, Dr. Jose, Dr. Aswath Kumar, Dr. Fessy Louis, Dr. Omana, and Dr. Venugopal, and dear friends and colleagues. Thank you very much at the outset for inviting me to make this presentation. Today, essentially, I'm going to concentrate on screening as one of the major pillars of cervical cancer prevention and a major component of the elimination of cervical cancer, particularly in the short term. So we will deliberate which is the most ideal test and how it can be utilized in the physician's offices as well as in public health programs. I'm going to heavily rely on the most latest recommendations from WHO, which was published 4 days back on July 4, 2021. Quite often people use elimination and eradication interchangeably, but these are very specific terms. Elimination means reduction of a disease to a very low level that it ceases to be a public health problem. So what is that threshold which will be decided by discussions? So in the case of cervical cancer, WHO, after several consultations, has decided if we can bring down the incidence of cervical cancer to less than 4 per 100,000, that is elimination. So that is the threshold, 4 per 100,000. But the difference between elimination and eradication is this continued intervention measures are required to keep the disease low. You cannot stop the intervention. For example, one day, Kerala arrives at 3 per 100,000, and we have vaccinated, we have screened. Can we stop those interventions? We cannot. We have to continue. If you stop them, the disease will come back. But on the case of eradication, the disease incidence becomes 0, like smallpox, and all the intervention measures can be stopped. So a typical example is smallpox, and for which the WHO has gained all the reputation. Still it holds WHO in a very good position. Now, coming to the natural history of cervical cancer, as our esteemed previous speakers mentioned, cervical cancer is the cancer where we understand the natural history very best out of some 300 and odd cancers which occur in the world. We know the natural history exactly. We know the reasons, the cause, and how it is caused, and how it progresses, and how the progression can be terminated. So cervical lesions are caused by persistent infection with one of the 14 high-risk types of human papillomaviruses, which are like 16, 18, 31, 33, 35, 39, etc., etc. But fortunately, despite HPV infection being the most common infection of the reproductive tract, most of the high-risk HPV infections are transient and clear by 2 years. If today 100 women are infected with HPV infection, high-risk HPV infection, with these 14 high-risk types, 2 years from now, in 85%, it would have cleared by itself. How it clears, nobody knows, but probably immune mechanisms, or it can go into a latency. But on the other hand, among these 14 high-risk types, HPV 16 and HPV 18 cause most of the persistent infections. They don't disappear as fast as the other HPV types. and they are responsible for 85% of cervical cancers in India. In other words, cervical cancer, the necessary cause of cervical cancer is HPV infection, but not all the people who are infected with HPV lead to cervical cancer. So without HPV infection, cervical cancer cannot occur. So this is very clear. And generally, you have different definitions of persistence. From a research perspective, persistence is defined if you do 2 HPV tests at 6 months interval or 1 year interval, and if the same HPV type present, then it is called persistent infection. But this is not useful for clinical practice. From a clinical perspective, a positive high-risk HPV test in a woman above the age of 30 years probably indicates a clinically valid persistent infection. So in apparently healthy people without HIV, any HPV infection detected above the age of 30 years is a persistent infection, and they are the candidates at very high risk for cervical neoplasia. And in the case of HIV-infected women, any HPV infection detected above the age of 25 years is probably persistent infections. And HPV 16 and 18 infections persist longer than other high-risk HPV types. And that is why they are responsible for most cervical cancers across the world. In Africa, it is responsible for about 70%. In the Americas and rest of Asia, about 75%. But in the Indian subcontinent, about 85% of the cancers. This is the most widely shown PowerPoint content in the world currently. Professor Seren sir and many of them pointed out this. The WHO's 3-pronged strategy to eliminate cervical cancer expects all countries to vaccinate 90% of eligible girls against HPV infection before the age of 15 years. And screen with a precise test. Now, WHO says a precise and very accurate test, 70% of the eligible women, at least twice in their lifetimes, at the ages 35 and 45. And effectively treat 90% of those with a positive screening test or a cervical lesion. So by 2030, the WHO expects all the countries to put in these interventions in place so that after 2030, gradually cervical cancer start disappearing in many countries. But some of the countries like Australia and Finland, which have very strong programs, which have already achieved nearer to these targets, they will be eliminating cervical cancer by 2028 or 2030. So we have 3 cervical, so we are going to concentrate on cervical cancer screening in this particular presentation. So there are 3 cervical screening tests which are very popular. One is visual inspection with acetic acid in low resource settings, particularly in Africa and Central America and the Indian subcontinent. Its sensitivity in the best hands is around 55%, but it ranges anywhere between 10 to 80% in different places. And its specificity, the best specificity achievable is 80 to 85%, but the specificity varies between 40 to 90% in different places. Cytology is similarly accurate, similarly sensitive as VIA. In the best laboratories of the world, it has a sensitivity around 58%. It will miss 42% of the lesions in a given screening round. But in a routine case, in many, many laboratories of the world, the sensitivity of cytology is only 30% or 20%. And this is very striking. And the way cervical cytology has worked is because of a repeated screening at 2-year or 3-year intervals. So in the lesions missed in one interval will be picked up by the second or the third interval. So the frequent repetition has helped cytology to reduce the cervical cancer incidence in countries where there is strong programs with all components in place, like testing, quality assurance, well-trained providers, and diagnosis and treatment and follow-up care. Now, finally, the test of the future or the test of the current period is HPV testing, DNA testing, particularly DNA testing. It is the most accurate cervical screening test. Its average sensitivity is 96%. So in a given round, it misses only 4% of the lesions. And its specificity, the best specificity is between 90 to 95%, but it can vary between 70 to 95%. So this is just to show a meta-analysis. A meta-analysis, a pooled analysis, which has sufficient power to detect even small differences. So it combines various studies across the world. And the only study from developing countries included in the meta-analysis, the Indian study conducted by us in several centers. And this showed HPV testing is at least 14% higher sensitive than cytology. But in all practical purposes, it is much more than that. So there is very clear evidence it is highly sensitive. And then other thing we have another important piece of evidence comes from randomized trials. In fact, the results from randomized trials give us the highest evidence level. Any treatment protocol has to be changed only when there is evidence from randomized clinical trials. So similarly for prevention, this is also important. There was a major randomized trial conducted in Barshi district, Osmanabad district in Maharashtra, in collaboration with Tata Memorial Center and the Nargis Memorial Cancer Hospital, which sort of randomized almost 130,000 women into 4 groups. One group is a routine care group, and the second group was they were given a single round of HPV testing by hybrid capture 2. And the third group was given a single round of cytology, a very high quality assured cytology. And the fourth group was given a single round of visual inspection by well-trained workers. So after 7 years of follow-up, what we found was there was a 50% reduction in cervical cancers and a 50% reduction in cervical cancer mortality following HPV testing, whereas the 11% reduction in mortality following cytology and visual inspection with acetic acid did not reach statistical significance, maybe a power issue. But clearly it showed HPV testing is highly sensitive and highly effective in reducing cervical cancer incidence and mortality. And the most interesting point is, if you test someone with the HPV test after the age of 30 and the test is negative, the negative predictive value of the test is very high. That means for the subsequent 10 years, 10, 15 years, the lady developing a cervical precancerous lesion or cervical cancer is practically nil. So this is the evidence again coming from Osmanabad district after 15 years of follow-up. In the HPV negative women, almost 28,000 women followed over 15 years. The incidence of cervical cancer was only 3.6 per 100,000, as opposed to around 28,000 cytology negative women, like 13 per 100,000, and about 30,000 VAA negative women, it is 24 per 100,000. So it shows considerably high negative predictive value of a single negative HPV test and entry. And added to this evidence, there is a very important piece of evidence coming from Europe in Italy, a randomized trial again, which randomized around 94,000 women, half of them to cytology and half of them to 2 rounds of HPV testing. And overall, it prevented 50% of the invasive cancers in the HPV arm as compared to the cytology arm. The relative detection of CAN 2 to 3 lesions associated with HPV was 2 times higher. That means if 50 lesions are detected by cytology, HPV detects 100 lesions of CAN 2 to 3. And in fact, the real true precancers for cervical cancer is CAN3 and adenocarcinoma in situ, and a basket of CAN2, and CAN1 is at low risk for transformation. So this also showed HPV screening is very effective. Then there were 3 other randomized trials which were conducted in Sweden, Netherlands, England. So our Italian colleagues did a pooled analysis, putting all the data from the 4 randomized trials, so which considerably increased the power of observations, involving almost 180,000 women. And in fact, they showed there was exactly like in Barshi in India, there was a 55% reduction in cervical cancer incidence following HPV screening as compared to cytology screening. And in fact, in women with a negative screening test at entry, the relative risk was 0.3, indicating a high negative predictive value. So all the evidence is going in one direction, which is a very important piece of causality in medicine. So all these evidence bases have been examined by WHO, by a guideline development group, and very carefully considered, and they have come out with a set of recommendations, which was just published on July 4 this month. So WHO now categorically recommends a HPV DNA test as the preferred method for cervical cancer screening rather than VA or pap smear. And they have noted HPV DNA testing is simpler, objective, mechanically measured, highly reproducible, with inbuilt quality assurance, and prevents more precancers and cancer and saves more life as compared to VAA or cytology. And in the long run, it is cost effective. This is because you need not repeat this test as frequently as cytology and VAA. They have to be repeated every 3 years. But HPV testing can be repeated even by WHO definitions, even once in 10 years. So fewer rounds. And I would say even a single round is substantially effective. And the WHO further said for average risk women, that is non-HIV infected women, HPV DNA testing in a screen and treat approach should start at 30 years with regular screening every 5 to 10 years, that is given to the choice of the country. Most Western countries go for 5 years, but I would strongly say the developing countries can go for a 7 to 10 year interval, preferably a 10-year interval. And in the case of HPV DNA testing, in a screen, triage, and treat approach, again, you start the screening at 30 years. Why 30 years? Before 30 years, most of the women acquire HPV infection then immediately after sexual debut. And in most of them, it disappears by the age of 30. So if you do the HPV testing before the age of 30, you will pick up quite a lot of transient infections, and you will unnecessarily intervene with the diagnosis and treatment. So to avoid that harm, WHO has put it at 30 years. But in the case of HIV positive women, in Africa is 50% of the women are infected with HIV. And they are at very high risk for HPV infection. So they are and very high risk for cervical cancer. So among them, they advocate a starting age at 25 years and to repeat the test, HPV test, every 3 to 5 years, more closely repeated tests. And then one can stop the cervical screening after the age of 50 years if 2 consecutive negative screening results among the general population of women are women living with HIV. What it means is at the age of 30 and 40, they are negative. You can stop screening by 50. These are very categorical decisions. And again, WHO suggests that self-collected samples can be used for HPV DNA testing. They are equally effective as physician-collected or nurse-collected samples, provided you are using an RT-PCR-based test like COBAS or some of the mRNA tests. So this is very important. In fact, the cervical cells are collected in a particular preservative medium, depending upon the product. For example, for COBAS, it is collected in SurePath preservative fluid, which can remain in the refrigerator between 2 to 10 degrees Celsius for about 6 months without any problem. And the room ambient temperature can stay without losing efficacy for about 2 weeks. There are definite guidelines. So the WHO also defined the two approaches of HPV positive women. One is the screen and treat approach, in which the decision to treat is based on a positive primary screening test only. HPV test is positive, there is no clinical evidence of cancer, the lesion is in a type 1 transformation zone, which is fully visible, and the entire stomach-columnar junction is visible, and the lesion occupies less than 75% of the transformation zone. Then one can, without a biopsy proof, particularly if this lesion was associated with a HPV genotyping of 16 or 18, one can treat with thermal ablation or cryotherapy, which are very simple outpatient treatments. But if someone prefers a screen, triage, and treat approach, the decision to treat is based on a positive primary screening test, followed by a positive second test, which is a triage test, with or without histologically confirmed diagnosis. All these recommendations comes from a certain evidence base. In the case of HPV negative women, the woman does not have CIN or cervical cancer at the time of testing, and highly likely that she will not develop this over the next 10 years. So these women can be reassured, and repeat HPV screening may be done after 5 to 10 years. This is the biggest advantage of HPV testing, the high negative predictive value, by which you confidently say to a woman, you are okay, you come back after 10 years. This is just to show follow-up studies. This is from Sweden by Dillner and colleagues, which shows this is cytology negative women, the upper curve, and very rapidly the curve climbs up. And the incidence of CAN3, for example, 36 months after a negative cytology test is almost 50%. Whereas in the case of HPV test, it is around 5%, which is similar to the Barshi experience. So that is at the level of CAN3. But Barshi gives the evidence at the level of cancer. Cancer is cancer. There is no dispute about cancer. People can always dispute whether it is CAN2, CAN3, but there is no dispute. And if you see, this is the incidence curves. This is VAA negative women. Sorry. This is VAA negative women. This is cytology negative women. This is HPV negative women. In fact, up to 5 years from a negative screening test, there is no cervical cancer detected. And if it is detected afterwards, because they are under surveillance, they are detected in very early stages. Look at mortality. Up to 8 years following a negative HPV test, there is no single cervical cancer death in the HPV negative. So high negative predictive value, both for incidence and mortality from cervical cancer. So if the woman is HPV positive, the women may be screen and treated, or may be triaged further to confirm or rule out disease, and should be followed up closely to only detect future disease if current triaging proves normal. We'll see this in some detail. So WHO suggests that HPV DNA positive women in the general population may be managed either with triage or without triage. WHO suggests HPV positive women living with HIV infection may be managed with triage, and one should not do the screen and treat among HIV infected women. This is a major difference between the screen and treat indications between normal women and HIV infected women. In a screen, triage, and treat approach using HPV DNA detection as the primary screening test among the general population or in HIV positive women, WHO suggests using partial genotyping or colposcopy or VIA or cytology triage after a positive HPV test. What is partial genotyping? You do HPV testing, it detects, if the test is positive, one or more of the 14 high-risk types are there. Then in genotyping, it shows whether it is 16 or 18 or the basket of remaining high-risk HPV types. So this gives, just like a colposcopist, the cytological diagnosis of high-grade lesion always in the mind. So there is a high probability of disease. So whenever a genotyping result comes to 16 or 18, you should have the highest degree of suspicion and try to find disease. So this is just algorithmically show. So HPV test not before 25 years, that is in HIV positive, not before 30 years, normal women. If it is negative, reassure and rescreen after 5 to 10 years. If it is positive, either you can do immediate ablative treatment if it is suitable for ablation, or triage with another test like such as HPV genotyping or liquid-based cytology or VIA, or you can triage with colposcopy. So whichever is available there, you will use it. They are all equally effective in the triage setting. And then, particularly in the case of low resource settings, VIA positive, treat with thermal coagulation or cryotherapy. If it is suitable for ablation, if it is not suitable for ablation, straight away go for LEAP. VIA is negative, repeat HPV test after 1 year, and cancer is suspected, immediately refer. And if you do HPV genotyping, if there is a genotyping facility, most of the HPV machines now come with the same reaction. It gives genotyping as well. It is positive for 16 or 18 or both. You treat immediately with ablation after checking eligibility. Positive for other trips, you can triage with VIA. So if it is positive for VIA, treat with ablation. And if it is negative, you repeat after 1 year. So if the triage is in a woman who is HPV positive, but when we try to triage, the biopsy result is negative, they should be followed up with repeat HPV testing at 2 years to detect early disease in the case of general population of women, and they should be repeated at 1 year for HIV positive women. If the follow-up visit indicates HPV test positive, we investigate further. But if the follow-up HPV test is negative, they can move back to the recommended regular screening interval of 5 to 10 years. Finally, once a decision to treat a woman is made, treat as soon as possible. So what is as soon as possible? WHO gives a period of within 6 months to reduce the risk of lost follow-up. But within 6 months, we don't expect a dramatic change in the grade of the lesion. However, in women who are pregnant, differ after pregnancy. In circumstances when treatment is not provided within 6 months from diagnosis, reevaluate the woman before treatment. And the treatment methods for CIN. See, at the moment, there are 3 treatment methods which are very commonly used. For the ablative treatment, it can be done with very simple thermal coagulator or cryotherapy. Cryotherapy uses a refrigerant gas like carbon dioxide or nitrous oxide, which rapidly reduces the cervical tissue temperature to -20 degrees Celsius to -60 degrees Celsius, destroying the cells. But it takes almost a 3-minute freezing, 5-minute thaw, and 3-minute freezing, and it requires a regular supply of gas. And equally effective is thermal coagulation, which is a very simple apparatus via an electrically heated probe at 100 degrees Celsius is applied on the cervix for 20 seconds, which electrically kills the cells. And the advantage of thermal coagulation is the probe is small, so you can give multiple applications at the same time, overlapping applications to cover the entire transformation zone. But ablation can be used only in type 1 transformation zone when all the following criteria are met. The squamous junction is fully visible. If the lesion does not involve more than 3/4 of the transformation zone, there is no evidence of invasive cancer. All the others have to go for a loop electrosurgical excision procedure or a large loop excision of the transformation zone. For any reason, adenocarcinoma in situ is suspected. They are the candidates for cold knife conization or a large loop excision of the transformation zone with a reverse cowboy hat technique. So this is an exception. Adenocarcinoma in situ we should not miss. And the method, whenever we suspect that, is resort to CKC or LEDs. So once we treat, how do we assess cure? So now the WHO suggests that women from the general population are HIV positive women who have been treated for disease, CAN2 or CAN3 or adenocarcinoma in situ, should be reviewed after 12 months and a HPV DNA testing is done. And if the test is negative, they are cured. It is no longer they recommend cytology or BIA or co-testing. So there are various HPV type tests available in the market. More than 400 types are available. But one has to be very careful in choosing the HPV test. You have to choose a clinically validated test like hybrid capture 2 or Cervista or Cobas or Optima or whatever it is, depending upon the pricing and other characteristics. The Cobas HPV test is, for example, is a test which detects 14 high-risk types, and it gives genotyping for HPV 16, 18, and a pooled result for other HPV types. There's an inbuilt quality assurance with beta globin, and it can test around the 6,800 system can test around 1,300 samples in 24 hours. And there are robotics to minimize chance of contamination. But ultimately, the choice of a HPV test will depend upon the technology, whether they are clinically validated. There are only a couple of clinically validated tests, as I mentioned, and they are less than 10. Whether they are WHO pre-qualified, because the WHO looks into the characteristics and pre-qualified, just like our Covaxin is now undergoing a pre-qualification process. So if the WHO pre-qualified, then the quality assurance you can believe and then take in. So WHO pre-qualification is one of the most important criteria to choose in addition to clinical validation of the test. So there are very few. So these are based on signal amplification, which is like hybrid capture 2, RT-PCR based, which is Cobas, and mRNA based, which are like Optima. But WHO currently recommends HPV DNA based tests, as we have already seen. So finally, what can a gynecologist do to eliminate cervical cancer? We talk about European screening programs, North American screening programs. You know, the screening programs in the United States, Canada, and Germany are essentially provided by gynecologists. There is no organization. The gynecologists give to their clients the screening. Canada sticks on to a particular protocol, like once in 3 years cytology so far. And they start screening at the age of 25. But while as in the United States and in Germany, they do even once in a year, and they start at the age of 21 and things like that, fairly half-assed over screening which happens. But organized screening programs exist in Finland, Sweden, Norway, Netherlands, and Denmark and places like that. But only 30% of the screening tests are done under the organized program. 70% of the tests are done by gynecologists, which contributes to the pool of the overall general screening. So the gynecologists have a major role in individually taking up the topic of screening and providing screening services. And particularly in this point in time in India, one should use HPV testing whenever a woman of average risk, like 30 years and above, comes to the office. And then, thermal coagulation is an outpatient procedure. It's a very simple procedure. And wherever possible, the lesion can be treated. Please treat with thermal ablation. In fact, we have done programs where more than 400,000 women have been screened, research programs, of course. And 70% of the lesions are suitable for treatment with thermal ablation, which is I would say, which is the workhorse of treatment at the moment. The large lesions, of course, are the lesions which occur in a type 2 transformation zone where there is an endocervical component of the transformation zone, or type 3 transformation zone where the transformation zone is not visible at all to the naked eye. Then, of course, again, you will resort to leave. Now, coming to Kerala. Kerala has one of the lowest rates in the country. In fact, the most latest results are 6.8 per 100,000 in both in Karunapalli and Trivandrum registries. So what does it mean? It means many things. You know, in China and in Eastern Europe and Central Asia and the former Soviet Union, the cervical cancer incidence rates were around 5 per 100,000. But as soon as the systems collapsed, they started increasing with change of lifestyle. In Mao Zedong's China, it was very strict MOS. So the Shanghai rates fell to around 5 per 100,000 by when Deng Xiaoping took over as the president. China opened, prosperity came in, and now in China, in Shanghai, the incidence rates are 35 per 100,000, exactly like in Chennai 30 years back. So a falling rate today doesn't mean a guarantee against future rise, especially all over the world, the behavioral patterns are changing. Number two, a falling incidence rate facilitates disease elimination much more easily if effective interventions are available and earnestly implemented. You need not struggle with a huge residual burden. So to reach elimination target of, say, let us say like 3 per 100,000, Kerala is something like 4 per 100,000 ahead. So by providing, you know, if you want to reduce this to 3 per 100,000 in our lifetime, screening is very important because that gives the results in the short term. And then you vaccinate your girls now, so the future increase can be prevented. So everything acts as complementary. So Kerala should strongly consider providing at least a single HPV test between 30 and 45 years and implementing a HPV vaccination program. The HPV vaccine prices will fall. A Chinese vaccine is already licensed in China. It is undergoing WHO pre-qualification process. An Indian vaccine has completed phase 3. The results are being analyzed. It will be considered for licensing next year. These two vaccines will change the scenario, global scenario. The Indian vaccine, the production capacity is enormous. So there are some very important developments. And then, as Professor Saran sir said, Government of India should also, India is a Gavi eligible country. India, Bangladesh, Pakistan, Indonesia, despite our gross domestic per capita income is above 1,200, which is the usual benchmark for Gavi, Global Assistance for Vaccine Immunization. You know, what Gavi does is, Gavi procures a vaccine at a price of $4.9 and delivers to the country, and the country pays 1 cent. But such an approach can be done not by state governments, but by the central government. See, a cervical cancer comes. Model presentation is stage 2, stage 3. What do you need? You need very sophisticated radiotherapy. Look at that state-of-art radiotherapy machine. Capital investment around 20 crores. 5 to 10% annual maintenance costs. Gushes electricity. Swallows electricity. High maintenance costs and all those things. And this is external beam alone is not, in addition to the external beam, you need high dose rate intracavitary systems. But when you detect a pre-cancer CAN2 or CAN3 or a positive HPV test, you can simply treat with a handheld thermal coagulator, which weighs 240 grams, which is battery operated or external power pack operated. On the left side is the VSAP system, on the right side is the Lesion system, Lesion surgical system. And in fact, the Lesion surgical system was developed. I had a major grant from NCI while I was in IR, and with Dr. Walter Prandtl, who is the father of LEAP, LETS. This unit was developed. Prototypes were evaluated in countries like Brazil, India, China, Thailand, and places like that. And the final products were arrived. And this is the VISAP system on the left-hand side. They are all, the VISAP system works both on AC and DC, inbuilt power source and timer, and very simple to high-level disinfect, and costs less than 202.2 lakhs. And with a single charge, the Ledger system I have extensively used in China. We used to treat around 40 patients with one recharge of the battery. So these are very effective means of doing this. And then there's a tabletop German model available, which is VISAP, which is like 4 kilograms in weight. This is also, before the handheld systems were available, we were using this. And we have a major randomized trial ongoing in Zambia, which compares LEAP, cryosurgery, and thermal coagulation, which will recruit around 4,500 patients, screen-positive patients. And we have reported the results after 600 patients in the Lancet, which shows equal efficacy. LETS, cryotherapy, and thermal coagulation, they're all equal efficacy in comparable lesions. Okay. So in summary, what I've said is the take-home message is, screening is a very important intervention. And please use HPV testing, because India is no longer a very low-income country. We have the resources, and ultimately it is cost-effective. And even if you invest 1,000, 2,000 rupees in a test, if the test is negative, you stop screening for practical purposes. And if it is positive, you investigate and treat, even over-treat. And no screening program works without over-treatment. And in the case of cervical cancer, there has been umpteen number of evidence. Once the woman completes the reproductive life, I think the complications, the side effects, the reproductive complications are minimal, particularly with ablative treatments. With excisional treatments, there is substantial harms like premature rupture, premature labor, threatened abortion, spontaneous abortion, all those things. But the thermoablation and cryoablation are much safer procedures from a reproductive health point of view, vis-a-vis the future pregnancies and things like that. But among the ablative techniques, given the cumbersome nature of the cryotherapy, where you need to buy gas, cumbersome equipment, the problem of blockage of the probe, and the longer time it takes to treat, 11, 12 minutes. A thermal ablation, the short-term treatment, a short course treatment like 20 seconds, 40 seconds is worthwhile. Thank you very much for your kind attention.
Thank you, Dr. Sankaranarayanan. You have clearly conveyed the message that HPV testing is a precise and accurate test with a very high negative predictive value. And also the message that thermal ablation is a method to treat transformations on a type 1 or type 2 transformation. Is it type 2 transformation?
Type 1.
Type 1 transformation zone, with thermal ablation, which is a very simple method. I think it's a time that we have to act, and we have to promote this vaccination so that in the coming years we can eradicate cervical cancer. But at present, we have to concentrate on cervical cancer screening. And of the screening tests, this HPV testing is the best. And when I wrote my chapter in my book, I quoted your study in Usmanabad district, Karnataka.
Yeah.
I quoted this study. I was thinking, why you went to Usmanabad, why not Kerala?
Yeah, because the sample size was much lower. Kerala would have required much more sample size.
Okay.
The power, they do the same study in Kerala, we would have needed some 300,000 women.
Okay. I used to teach my students that if you are given an option to have a gynecological malignancy, you should opt for cancer of the cervix. Because that time I couldn't say that it is HPV. Because now it's clear that it is HPV. And we should be thankful to Sir Ferguson for the important discovery that it is HPV that causes cancer of the cervix. And when it comes to cancer, we have the cervix, which can be visualized and we can screen. And even if she develops an early cancer, we have the uterus to keep the intracavitary source and supplemented with the external radiation. And I have a doubt, Dr. Sankaranarayanan, when you treat with thermal ablation, as a screen and treat policy without histopathological diagnosis, can we miss an advanced lesion?
The experience says it is much less likely. If your clinical assessment of the lesion, type 1 transformation zone, fully visible lesion, and the lesion is completely ectocervical and with smooth surface and all those things, the possibility of missing an advanced lesion, an early advanced lesion like a microinvasive cancer, is very limited. In Africa, that is what they do. But in India, I always used to advise, before treating, just take punch biopsies. So a posteriori, you know what you treated. Suppose you treated an advanced lesion like a microinvasive cancer or something.
That's what I am scared.
Yeah. But the thing is, you will be surprised to hear, in Japan, one of the major means of treatment of microinvasive cancer is thermal ablation and cryosurgery.
Okay.
Yeah. So in Africa, this has been extensively studied, screen and treat, because when WHO came out with this recommendation, they have to be extremely careful because it's a World Health body and they should not be accused of doing some harm by taking a policy. So this has been very carefully addressed. And actually, there is much more harm in having a 2-visit, 3-visit approach where the people will be lost forever.
That's the main thing.
Main thing. And here, the thermal ablation, there is no excessive discharge. You can permit sexual intercourse the very same day. They can go to work. So all types of advantages are there. And then in Africa, they also showed it doesn't increase the risk of transmission of HIV infection. But this is, I mean, our HIV infected population is not as much as what you see in Africa proportionately. So all these safety parameters have been addressed.
So I think Dr. JEENA, we should also start doing HPV testing, because we should think as former Apple CEO said, every day you live as if it is the last day in your life. So we have to act early and start doing HPV testing, because when COVID came, so many centers developed this virus testing. So why not do the same test for HPV as well? And if COVID goes off, we can use I think the same technology can be converted to, can be converted to HPV testing, isn't it? TrueNat and TrueNat can be used for HPV testing.
TrueNat is, test for about 4 or 5 HPV types now.
Okay.
So we would prefer any HPV testing that would test for all the 14 types.
What about RT-PCR?
RT-PCR is good, but RT-PCR is also, it should have been clinically valid. There are many RT-PCR. There are more than 150 RT-PCR tests which have been developed, but many of them are not clinically validated. When we mean by clinically validated means, it should have been extensively used in programs and research studies and results documented, peer reviewed, and the data are available for scrutiny. In the case of cervical cancer, the most clinically validated tests are hybrid capture 2, COBAS, and Cervista, and Optima, the mRNA. So these 4 or 5 tests are among the most clinically validated tests. And then again, the problem in HPV testing is the equipment is expensive. So you need to have some type of a centralized equipment, either provided by a private service provider or a government service provider, whoever it is. And then where the gynecologists can seek, either encouraging their patients to have self-sampling, because you need only minimal number of cells for RT-PCR based self-sampling studies, or you collect the specimen and then send it by courier, because at room temperature, for the manufacturer says 2 weeks, but they protect their back. I would say it can go even up to 4 weeks, but don't quote me. But this is
DNA and RNA are stable molecules.
Yeah. So ultimately, I don't think whether the governments will systematically invest in screening and vaccination, given their financial situation. But the gynecologists can do quite a lot to their clientele. Whenever a suitable clientele above the age of 30 comes in, get a HPV test done. Negative, reassure them. Positive, you manage them. And the simplest way of managing is, in your office, you can have a thermal coagulator. It's a very, very simple procedure, very, very easy to treat and very easy to maintain, and there is no safety issues. Yeah. Dr. Omana has a question. Cost is the problem. Really, Dr. Omana, cost is not a problem, because we have to think cost in terms of cumulative costs. A good pap smear, there is no good pap smear available in many places. I would rate probably the cervical cytology at the Regional Cancer Center, Tata Memorial Center, the Nargis Memorial Cancer Hospital in Barshi, are probably, and then to a certain extent, Christian Medical College and places like that, as the most quality assured, reliable pap smears, because many laboratories, the quality of the pap smear is much lower. So you pay a certain price, you miss a large number of lesions. And then you have to pay repeated pricing for repeated tests. So ultimately, they are not cost effective. So there are a number of cost effectiveness studies which have looked into this. And HPV testing has been proved to be highly cost effective in many settings. So I wouldn't say cost is a problem. You invest 2,000 rupees and get yourself reassured there is no problem of a cancer in a particular organ. Or if there is a positive test, then there is a very easy way of tackling this rather than undergoing invasive radiotherapeutic or surgical procedures or concurrent chemoradiotherapy and things like which are very unpleasant forms of treatment. So actually it is cost effective, and I wouldn't say in layman language, it is very affordable.
So, it was a very excellent talk, and we all know what to do to eliminate cancer cervix as well as to prevent cancer cervix. I request that JEENA will continue this mission and passion and seek the help of Sankaranarayanan sir to get the vaccine at a subsidized rate with the help of the WHO or any other agencies. And all our gynecologists who have heard this, who are present this, should carry the message that we should advise all our patients who are coming to us and do the test, and also convince them that we have to spend some time talking to them the necessity of this, and assure them that this is very cost effective and affordable. And if we can assure them and convince them, most of them will come and they will do the test, and also they will give the vaccination to their kids. So this is a very useful thing, and this presentation was very excellent. I congratulate Dr. Sankaranarayanan for coming to this KFOG meeting and all giving all advice to our doctors. Thank you.
Thank you, sir.
Dr. JEENA, 1 minute. Can you spare me 1 minute?
Yes, sir. A lot of
Okay.
time.
Okay. With
So up to 2:30 we can use, sir.
now, with the concurrence of Dr. Sankaranarayanan. No, November 17th, this November 17th, there is a call from WHO that you illuminate all the monuments as far as you can, because public awareness is the most important thing behind all this activity. They should know the need for screening. They should know the need for vaccinating their children. So this 17th of November, all the monuments are to be illuminated by the color teal. It is a shade of blue, maybe bluish, greenish color. Qutb Minar is being illuminated. The Central Secretariat has been illuminated like that. And why not we recommend with the government of Kerala, illuminate the Secretariat, which is a very beautiful building, the old Secretariat. Why not we take up this one with a message on all the walls, around the wall of the Secretariat, that cancer can be prevented, it can be cured. That messages on that display on the morning time. From evening till the next morning, illuminate such important site. Probably at Calicut, we have got 2 flyovers. Why not we illuminate that? I was just thinking after seeing this call from the WHO. I think Kannur and Talassery, some banner is there already in the WHO site, in that video, with that monument, what is there in that quota. So why not we? It is already there in the WHO video. I don't know whether you have seen it or not. That from Talassery as well as Kannur is already gone in. With whose effort it is, I could not see what was the banner there. So like that, all of us make aware the public. Our people will agree if you convince them. Even if it is costly, they will spend for the health matters. The Kerala is the best example. People will be spending for the health matters of the family. So if they say, and I was telling that we doctors should take the initiative in the vaccinating our own kids, so that people get, if we are not convinced, then how can you impress upon the people that the vaccination is safe? We know that some tragedy has occurred in the pilot program, which is headed by Dr. Sankaranarayanan with his help in Andhra and somewhere else. It was something totally unrelated to vaccination, and that program was suspended at that 2009 or so. I don't know. I don't remember exactly. But restarted in 2016. The vaccination has been taken by Punjab and selectively in Delhi. So I was thinking that Kerala is always a model for other states in India, but we are lagging behind them. And we have to impress upon our authority. Without government support, no association like ours can do these wonders. As Sir was telling, we have to get the resources from something like Gavi, where the Nepal has covered almost 70% of the teenage girls on vaccinating. The Sikkim has done it. Maldives have done it. Of course, Australia and other countries, they have got the money and they have covered more than 70% or 90%. So we have to go ahead, impress upon our authority, and I think we have to use the contact with our politicians on this positive thing. We don't believe in any politics or whatever our political commitment is different. But we have to use the authority of the government to establish and start such program. I think KFOG will take at least one step, that is the making aware by getting the help of the Kerala government and the KFOG illuminate the Secretariat on 7th of November. As advertised, it will attract the media attention will come there, and that will cause that there is an injection possible to prevent cancer. There is a screening method where you can detect the cancer at least 10 years ahead and treat it and cure it. So this is the message that we have to spread across, and then only this program will go on, and the next generation may go, hopefully JEENA and others, that you are responsible for making cancer-free Kerala. So we have to go ahead with it with a full zeal and support, not that one Dr. Sankaranarayanan has done from
Where are you?
all over the world. We have to make use of his and utilize his advisors. You can't get a better person in the world to advise us. So make use of his very friendly attitude towards her and make use of his support. So thank you very much. Thank you, Sankaranarayanan sir, for all this effort. And we know that we had a lot of speech in between your presentation. Sorry for that, keeping you waiting, but it was worth listening to you. Everyone who has listened has learned many things. And thank you very much once again on behalf of KFOG and Dr. JEENA in particular. Thank you, JEENA.
Yeah, thank you, sir.
Thank you, sir.
Dr. JEENA, can I take a moment, 1 moment?
Yes, yes, yes.
I completely agree with Saran sir. I think awareness creation is very important. And gynecologists talking to their patients and clientele's bystanders will make a huge difference. And then sourcing facilitating HPV testing for them. And there was a question about the CARE HPV. Yes, CARE HPV is a clinically validated testing. Actually, CARE HPV was developed through Bill and Melinda Gates Foundation assistance to the Chinese Academy of Medical Sciences and IARC, as well as Tata Memorial Center and Northeastern Memorial Cancer Hospital. It was jointly developed. It doesn't have genotyping, but it is used. It is a clinically validated. And hybrid capture 2 is again clinically validated. But it is not one reaction which gives the genotyping. You have to have a second reaction to give the genotyping. I mean, that has been extensively used as well. Thank you.
Sir, can you give some insight into this vaccination study in Andhra Pradesh? Our gynecologists are reluctant to do this HPV vaccination due to this bad propaganda.
Yeah. You know, in Andhra and Gujarat, the government of Gujarat, government of Andhra, the Indian Council of Medical Research and the Program for Appropriate Technology in Health in the US obtained funding from the Gates Foundation and implemented a routine HPV vaccination program, quadrivalent vaccine in Andhra and bivalent vaccine in Gujarat, through their existing healthcare system to study whether the vaccine can be given through, are there any challenges. So it was not a clinical trial. It was a demonstration project or a pilot project to implement and see what things needed to be improved. That was a study. So they recruited 20,000 girls in Andhra and 20,000 girls in Gujarat. And they obtained a consent, from some of the girls, it's an individual consent. And for some of the girls, it was group consent. Group consent means for a group of people, like in a village, the village headman will give the consent. It is commonly used in epidemiology studies, even though I am not a big fan of it. Tomorrow, somebody will come and ask, who is he to give consent for my daughter? So there were some group consent coming from hostels of girls and things like that, which was a problem, which created some misconceptions. And both the studies went very well. And it was, ICMR was directly involved in the studies along with the two governments. And what happened, once the vaccination was over after a few months, some girls died of organophosphorus poisoning, some girls committed suicide, snake bites. I mean, as Professor Saran sir said, all these were not at all related to the vaccine, but it was all misconstrued as, a vaccine-related deaths and things like that. The government asked this to be investigated. It was investigated, and they found that these are not related to the vaccine. But unfortunately, nobody took a very strong, vehement view, a vehement stand, either the Indian Council of Medical Research or the governments, right from the beginning to tell, what has really happened and give a counter response. So that was very unfortunate. That resulted in suspension of all vaccines in the clinical trials but the licensing for practice was continued. So this is the contradiction. You know, they said, oh, in all clinical trials, you stop it. And at that time, we were recruiting in a major clinical trial to compare 2 doses with 3 doses. 20,000 girls need to be recruited, 10,000 in the 2-dose group, 10,000 in the 3-dose group. We had recruited 17,000 in 3 months. The recruitment went very well. And when the government stopped the recruitment in clinical trials, we had to also stop. And that was a good thing by disguise. We not only proved a 2-dose is as good as a 3-dose, but there were 5,000 girls who received only a single dose. Now the single dose arm is doing very well as compared to the 3-dose and 2-dose. So even, you know, there might be a 1-dose recommendation in the near future. It's quite possible, which will make HPV vaccine delivery much more easier because it's a single dose. You know, you need not go back and trace the people for the 2nd dose, 3rd dose, and things like that. So in nutshell, the deaths were not related to vaccine. This was misinformation. I think the vaccine misinformation was maximum in India, in Japan, and in Colombia. You know, in Japan, what happened? They said it is associated with regional pain syndrome. So from 90%, the vaccine coverage fell down to 1%. And the government said an equivocal statement, we do not, or we do or we do not promote vaccine. They took a neutral stand. But in Colombia, few girls fainted after getting vaccination, and the girls were carried, and the television caught these pictures, and this was transmitted. So this created a furor, and then the vaccine coverage fell. But the Colombian government and the Colombian Minister of Health took a very strong stand and went ahead and saying that this is not true. And actually, I traveled to Colombia to support their, you know, the truth dissemination procedure, going to the TV and then speaking. So it all depends on how you respond to a situation. You know, we have done clinical trials. In the clinical trials, many things can go wrong. One need to have a strategy of managing adverse publicity, a strategy of managing side effects and things like that. And moreover, you have to be very honest and upfront.
Thank you, sir. One question from Dr. Ajit sir, our president, is that what specific recommendation KFOG can give to the government of Kerala regarding screening? Can we get help from WHO for screening?
Yeah, you know, WHO is a policy-making body. WHO has very limited resources. But one thing which Kerala government can do is Kerala government can implement a HPV screening program, and taking into account all the machines available both in the public and private sector, it becomes a public-private participation, which is the model to go across. In many places, it is that model which works. And then the Kerala government should get a negotiated pricing, the Gavi pricing. That is what Sikkim and Punjab and Delhi have. What they have done is they wrote to the government, the central government permitted, but they said, oh, you use your own resources. And then they went to UNICEF asking for free vaccines, but the Gavi application has to go by the central government. Central government won't give. But these governments negotiated with the vaccine companies through the UNICEF Gavi system and got the vaccine for $4.9, the Gavi price. That substantially reduced the cost implications of the vaccination. So when the Indian vaccine comes next year, I think Kerala government should consider implementing this vaccine, targeting a single age group like 10 or 11 years old through a school-based program. And by that time, if the single dose recommendation comes in, they can even go for a single round. But for screening, they should concentrate on a single lifetime screening between 30 and 49 years with a validated, clinically validated HPV test like COBAS or hybrid capture 2, whatever it is. But rather than government investing heavily, because what happens, there is a lot of government investment in the Cepheid gene export. There are many machines available, but when you try to share these machines, it is very difficult. And these are cartridge-based systems, 1 test, 2 tests, 4 tests, and things like that. When you have a mass program, then you need to have a mass testing facility. So through a very carefully considered public-private partnership, the government can implement this by paying an unit cost per test, so that the private sector puts the equipment and the service and takes care of the sample transportation, reporting back the results and things like that. I think even before the government goes into such a thing, I think there is a very important opportunity for Indian gynecologists now, to use HPV testing, because there are many players now who will provide the HPV testing for about 2,000 rupees or whatever it is. Some of them charge 4,000, some of them charge 2,000, but a societally conscious charging system will be a small amount of profit above the cost of the kit and things like that. So this is the model that we need to go. And then the gynecologist should be ready to manage the cases in their offices. And actually, thermal ablation can be managed in the office. You don't need a complicated hospital system. But in the case of LEAP, then they should have arrangements in a hospital system to do LEAP. That is again an outpatient procedure. We have even trained nurses in doing LEAP in some countries, single pass LEAP. So most of them will require a single pass LEAP. So these are some of the things which needs to be concentrated. And KFOG as a professional organization, I should compliment the obstetrics and gynecologists across the world, whether it is FIJO, FOXI, they work very closely with governments. And they have a public health consciousness, and they recommend things, and they are closer to governments, and their contribution towards reducing maternal mortality and child mortality is remarkable. But this is not the case. Unfortunately, I'm an oncologist, but this is not the case with oncology associations. So you have a very good standing. So in Kerala, the KFOG can spearhead a program with government blessing, but relying on the private sector to the testing and relying on your expertise to treat them and provide them follow-up care. So it works out to the advantage of everyone involved in the program. The government gets coverage, the private sector sustains, and you as a part of the public sector provide screening and follow-up care at affordable costs. So this is the type of thing in the short term we need to go around. For 25 years, I have knocked at government doors in many countries, and I have found the entire Southeast Asian region, working with countries like Thailand and Bangladesh, Bhutan and places like that, they are more receptive, because either they have lesser problems than us, lesser competing problems than us, or there is a way to go. Particularly Thailand is very impressive. The proper health technology assessment, proper piloting of the studies, and only when they are convinced, they put a threshold for the pricing they will pay. And when that threshold comes in, the companies agree, they put the program and phased coverage. They have 75 provinces. So they don't cover all the 75 provinces on day one. They take about 3 to 4 years to cover, 20 and mop up. So some of those things are governmental responsibilities, but as a professional organization, you would encourage opportunistic screening by informed gynecologists, seeking through the private sector testing and through your own resources, diagnosis and treatment of the screen positive. And resort to HPV testing, because the biggest advantage is HPV negative women, leave them alone. Leave them alone. This is a major message I would like to give.
Can we approach the Gates Foundation?
Okay, the Gates Foundation had a lot of interest in cervical cancer prevention. So they were the major drivers of some of the cardinal studies across the world through an alliance called Alliance for Cervical Cancer Prevention, in which IARC was a member, and I was the lead for the IARC component. They have invested heavily in Gavi. You know how Gavi gets money. Gavi gets money to buy vaccines from the US government, Germany, France, Italy, and UK. And then in addition, some pharma companies contribute a bit. And then philanthropists like the Gates Foundation, they contribute. But with a political nexus or with a political thinking and a political perseverance, one can seek funding from the foundation and say that we would like to show this, demonstrate this in one district or two districts of Kerala, that we can really eliminate cervical cancer.
You should go through the government, Gates
Yeah,
Foundation.
you can go through the government. You can even a private party can go through, but this is at the policy level, so it is always better to have the government's blessings. Okay, say for example, the regional cancer center can go with an application with government blessing and in association with KFOG to just write a half-page note to the Gates Foundation saying that what you would like to do, and if they are interested, they will come back and tell you, give me a 4-page, 6-page proposal. So anything is possible. You have to knock at the gates of the different resources. And in fact, all our cervix cancer research studies over the last 25 years, it has been supported by the Gates Foundation. And in fact, even after my retirement, the support from the Gates Foundation continues to IR to complete follow-up and all those things.
Let us request all gynecologists to orient the public about this vaccination and screening.
Yeah.
Okay.
Thank you, sir.
I think I'll request Dr. Ajit, Dr. JEENA, and Dr. Venugopal to make a draft sort of a application and get it corrected by Dr. Sankaranarayanan to our government. Thinking about this Gavi and how it works and all. Really, if you want to do something collectively, you have to get a proposal going through the government. So make a support, make a document with the help of Dr. Sankaranarayanan and then place it, send it for recommendation to the government of Kerala to be forwarded like that. We must start somewhere. May not come through immediately, but let us start. And as I repeatedly say that we have got Dr. Sankaranarayanan to help us always. So let us make a draft, the government of Kerala, as we could hear from the DHS also, and as well as the MLA, who was the previous health minister. We can approach these people with this health program for the public. They will be receptive, and we are showing our our willingness to help the government also. So like that, we make a proposal, try to do something, and create public awareness about vaccination and screening. I think we may make an impact sometime in the near future. So that is the conclusion of the today's this thing. It was great to get Dr. Sankaranarayanan, and thank you, sir, for your presence here and giving us all the inputs. Thank you once again. We will approach you again and again, probably, if at all we think of doing something, not to limit to a webinar, but to do some action we will hope to do. Okay, Dr. JEENA.
Thank you, sir.
Dr. Ajit, sir. Ajit, sir is here.
Yeah.
Yeah,
Sir.
JEENA, it was an excellent talk, actually. I think even the DHS was very willing to cooperate with us. So we will definitely make a project, at least to screening between 30 and 50 years by HPV testing. So we can recommend it to the government of Kerala. And again, the private hospitals, the patients will pay for that. In the government sector, we'll work out what we can do. Then again, the vaccination also, we'll try to do something. Anyway, thank you. Thank you for this.
Thanks.
Then Shankar sir, about the leave procedure, we will try to propagate the leave procedure. And we are not doing at present. Kerala nobody is doing this. RCC is doing, but
Rama
we
and
will
Sujata
propagate.
are doing, and they have a training program as well. And then they train some in-service training for the government doctors in recent months. But there is a good training facility for the entire gamut of cervix cancer prevention, including cryothermal and the LEAP and all those things there. And then we can also collaborate with you directly to put in these programs in the training programs in place, especially to train master trainers so that they can train others. I mean, that will give you a cascading effect, because training providers is a large number, but you train master trainers, 2 or 3 master trainers in each district if you can create, and then they can transmit the skills under the auspices of KFOG and Carcanos and many other organizations as a procedure, so that the whole program, the screening is not only testing, but diagnosis and treatment and follow-up care. We can achieve that goal.
Sir, KFOG Oncology Committee will do that, sir. Then one apology for that. This technical team make this 100 participants as the upper limit. So many of the gynecologists cannot join the program. So I am unaware of this. So my apologies again. So if possible, sir will give some another session.
Sure, madam.
Possible. So,
Yeah,
because
we can get the recording and we can put it on YouTube.
JEENA madam, that it will be available on our YouTube channel.
It will be available on YouTube.
Yeah, yes, it will be available.
Sankaranarayanan sir, for the very informative talk and the advices. Very much thankful to you, sir.
Thanks, ma'am.
Now is any other question answers? Otherwise, we can move on to our out of time session. I will see.
Any contraindication for vaccination, any debilitating illness, we wouldn't vaccinate. But otherwise, there are, it is like a routine vaccination.
Shall I?
How I will.
Yeah. Very good afternoon to all of you. I think it was an excellent session. And if I were to summarize it up in a few words, I think this session, the talk and the deliberation that followed itself was an important milestone in KFOG and the oncology committee's endeavor and the path to elimination of cervical cancer and making Kerala cervical cancer free. I wish to specially thank Sankaranarayanan sir for a presentation which was a demonstration of clarity, his passion and dedication towards the cause, years of dedication towards this particular cause, and it was filled with messages, suggestions for improvement of clinical practice, and also for influencing policy and making policy decisions which are of importance. Thank you very much, sir, for coming and to this meeting, and we are privileged by your presence. And the deliberations that followed, I want to thank Tegaran sir, Prasanna Kumari and Gopinathan madam for very effective deliberations, which I am sure will result in a few changes. On behalf of KFOG, I think we wish to assure and Sankaranarayanan sir that we will be in touch with you, and we will require a lot of suggestions for you, for implementation of these programs. Thank you very much, sir, from the bottom of our heart. I am also wish to thank the chief guest of the day, Shailja teacher and Dr. Ramesh, who eliminated this webinar by their very, by their esteemed presence. Also, I wish to thank
I wish to especially congratulate JEENA madam, because I think it's your initiative which led to this session, which would have benefited all KFOG members. And I want to also tell the others who couldn't attend today, they will not miss any part of it, because it will be uploaded on our YouTube channel as soon as it is made available to us. I wish to thank Dr. Jose, our Vice President. I wish to thank Dr. Ashwath, Dr. Fesi, and Omana madam, all of whom, bits and pieces contribute to a success of any meeting. So I wish to thank everybody. And last but not the least, each one in the audience who are part of today's meeting. Thank you very much on behalf of the Kerala Federation of Obstetrics and Gynecology. So thank you, until we meet again. Thank you very much.
Thank you, sir.
Thank you.
Thank you.
Thank you. Thank you. Thank you, sir. And thank you, Dr. JEENA. Thank you, everyone.
Thank you, sir.
Thank
you.
you, everyone.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Nice to see you.